Good morning, dear delegates. The pretest has been shared in the WhatsApp group. Kindly find the attachment and complete the pretest. Good morning, everyone. Without much delay, we will move on to the sessions for today. I would like to welcome Dr. Saranya Ma'am, Associate Professor and Officer in Charge, Anatomy, JIPMER Karaikal, and Dr. Vijay Kishan Sir, Assistant Professor, Anatomy, JIPMER Karaikal, to deliver their talks on Principles and Practices of Anatomical Embalming, a review of techniques and adaptations.
Good morning to all. Once again, welcome you all for this for the online CME. And so myself, Dr. Vijay Kishan, Assistant Professor, Department of Anatomy. So I'll be presenting on the topic. So I'll be presenting on this topic, embalming chemicals. So in which I'll be discussing about the important and most commonly used embalming chemicals in routine embalming procedures. Right. To start off, so I'm starting with the question why. So why do you think the embalming is done, or to say it in another way, what are the goals of embalming? So it has many goals, as in, like, so the first one of it is to preserve the tissue. So that is tissue preservation for a longer period of time, and then and after that, to prevent the bacterial or fungal growth, and the next one is to prevent excess hardening, and then to make sure that, or to try and return the uh, original color and texture, to prevent drying excessive drying of the tissues, and finally to reduce to reduction of the risk of being a health hazard. So all these are mainly the goals of embalming, that why we do embalming, for the preservation of tissues, and to prevent the bacterial or the fungal growth, prevent excess hardening, so retention of color and the texture to the extent possible, to prevent excess drying, and reduction of risk of being a health hazard to the person dealing with them. So how these goals of embalming are achieved? How do you think these are achieved? Yeah, so these can be achieved by using this chemical groups, so which I'll be discussing briefly about in the embalming solution. So we have various chemical groups which can be used so that the goals of those embalming are achieved. So coming to the chemical groups that are used in the embalming solution, firstly the preservatives, also called as fixatives. And next, the next chemical group are the disinfectants or the germicides, so which basically helps prevent the growth of fungus and bacteria, and preservatives, which basically help for the preservation of tissues. And the next chemical group that are used in the embalming solution are the modifying agents. So these are all included in the modifying agents, that is buffers, humectants, anticoagulants, and surfactants. So we'll be discussing about the uses of these modifying agents, so how they modify this embalming solution, right. And the next chemical group that I'm going to discuss about are the dyes, order passing agents, and the diluents. Okay, so these are the basic chemical groups that are used in the embalming solution for the routine embalming procedures. So yeah, so firstly, so each of it will be discussed briefly. So firstly, starting with the preservatives. Yeah. So preservatives, so as the name itself suggests, that they help in the preservation of tissues, uh, and also called as fixatives. So how do they act? So they basically act by coagulation of proteins and thereby delaying the decomposition. So the most commonly used preservatives that we all know is formalin. Yeah. So we have the other preservatives as well, like glyceraldehyde and the phenol alcohol. So those can also be used, but the most commonly used one is the formalin. So briefly about the formalin. So what is it basically? It's basically a fluid, or the commercially available fluid, which has this following components, that is formaldehyde gas and methanol. So that's what is constitutes the formalin. And if you see the percentage of formaldehyde gas that's present in the formalin solution is about 37% by weight. So that's what the formalin is made of formaldehyde gas and methanol, and this is what the percentage of it that's there in the formalin solution. So what are the so now that we know that this is the most commonly used preservative, so let us see what are the important advantages of it. Yeah. So there are so many advantages of the formalin. So one being, it is as we all know, that it is an excellent tissue fixative. So it fixes the tissues. And another important one is that it can be used as a disinfectant. So it has this bactericidal action. So it can also be used as disinfectant. It has that action too. And another important advantage of the formalin is that it destroys the autolytic enzymes of the cell. So these are the important advantages of formalin. So it's being used as tissue fixative and can also be used as a disinfectant, which helps uh, prevent the growth of bacteria and fungus, and also destroys this autolytic enzymes of the cell, so that thereby preventing the autolysis. So these are the basic advantages, and moving on to the disadvantages. So it has some disadvantages too. That the most important, very important disadvantage of the formalin is that it causes hardening of tissues, thereby causing rigidity. Very important. So that is one of the disadvantage of formalin, hardening of tissues, thereby causing rigidity, and also restrict the movements at the joints. And so next disadvantage is that excessive use of formalin can cause constriction of capillaries. It causes constriction of capillaries when it is used excess in embalming solution. So thereby it restricts the distribution of fluid to the deeper tissues. And another important disadvantage is that it coagulates the blood. It rapidly coagulates the blood. So both of which prevents the distribution of fluid or hinders the distribution of embalming solution. Yeah. And it's also a weak fungicide. It's not that an effective fungicide. So it's ineffective against fungus. And some of the disadvantages to the personnel who are dealing with formalin, or that it is a carcinogen. It is associated with the risk of causing respiratory tract carcinomas, and it also causes, as we all know, it causes irritation of eyes, nasal mucosa. So these are the disadvantages. So the most important one being the rigidity, hardening of tissues, and constriction of capillaries, rapid coagulation of blood. So both of which prevents the distribution of embalming solution to the deeper tissues, and the other one being being an ineffective against the fungus, and being a carcinogen and causing irritation of eyes and nasal mucosa. And we're going to see like how all these disadvantages are compensated. So they have some other components in the embalming solution which compensates for these disadvantages. Yeah, so we'll be seeing that in the further slides. So that's about the preservatives. So we've discussed the most important one, that is formalin. So another important one, as I discussed, is glutaraldehyde. Another important preservative is that. So it's basically the advantage of using this over formalin.
Recording in progress.
Is that it causes less hardening of tissues. So that's the main advantage of glutaraldehyde, is that there's a lesser tissue hardening. So because of which glutaraldehyde is commonly used as preservative for embalming the cadavers which are used for surgical skill training. Yeah. So this is the this preservative choice in case of for the embalming solutions for the surgical skill training. So that's about the preservatives. And moving on, disinfectants. So yeah, as we all know, the name itself says that disinfectants or germicides, they basically prevent the growth of bacteria and fungus. So how do they act? So they act by they inactivate these microorganisms by acting on their protein component. And the commonly used disinfectants are these are the alcohols, including methyl alcohol, ethyl alcohol, and phenol and thymol. So we'll be discussing briefly about these four examples, that is alcohols, phenol, and the thymol. The firstly, the alcohols. So the important advantage of alcohols is that they are excellent bacteriostatic and bactericidal agents. And so to be specific about the methanol, it's that it's a very good germicide, and which has high tissue penetration capacity. So that's the main advantage of methanol. And coming to the ethanol, so the action of it will be more effective when it is diluted in water. So when diluted in water, it has this best germicidal effect. So those are the briefly about the advantages of this. So both are disinfectants. One with high tissue penetration capacity. The other one is best can be used when it is diluted in water. And coming to the disadvantages, so they do have some disadvantages, that methanol, to be specific. So if it is accidental ingestion of it may cause blindness and death, and ethanol can cause the depression of CNS. So one more important thing about the alcohols is that like they can also be used as preservatives. So that's about the alcohols, which are commonly used as disinfectants. And moving on, another important disinfectant is the phenol. So phenol is basically a white crystalline solid which is derived from coal tar, and it is highly toxic. Yeah. It's highly toxic, and it has high tissue penetration capacity. So this, just like methanol, it also has high tissue penetration capacity. So some of the advantages of it, of the phenol, is that it's an effective fungicide. It's a highly effective fungicide. So unlike these alcohols, which are highly effective bactericidal and bacteriostatic, but phenol is highly effective fungicide. Another important use of the phenol is that it is more commonly used in other than not in this other solutions like this cavity embalming, hypodermic injections and surface embalming. Yeah, so it's less used in arterial solutions. So it is more predominantly used in the cavity embalming, hypodermic injections, and the surface embalming. And another important advantage of it is that it is a highly effective fungicide. So coming to the disadvantages, as we have I have previously discussed, that it is highly toxic and it causes graying of tissues. So that's one very important disadvantage of phenol, is that it causes graying of tissues, and it causes chemical burns when it comes into contact with skin, and when it is ingested accidentally, it can cause blindness and death. Yeah. So that's about the phenol. It's an effective fungicide, and it is more commonly used in cavity embalming, hypodermic injections, and surface embalming. And next disinfectant briefly I'm going to discuss about is thymol. So thymol is also available as crystals with characteristic order, that it has colorless crystals, and just like the phenol, it is also and one more important thing about thymol is that it is soluble in ethanol, and it's not soluble in water. So whenever the thymol has to be used, it has to be dissolved in ethanol, and then it has to be used in the embalming solution. So that's one important thing about the thymol. So it is soluble in ethanol, and it's not soluble in water. And it is also an effective fungicide. It's just like phenol is an effective fungicide, and it is commonly used in the arterial solution, that is arterial embalming solution, and the tank solution. So the phenol is more commonly used in cavity embalming, hypodermic injections, and surface embalming, whereas thymol is used in the arterial embalming solution and the tank solution. So that's about the disinfectants. So we discussed about alcohols, uses of alcohols, and then about the phenol and thymol. So both being effective fungicides, one being used in cavity embalming and the other being used in arterial solution. So coming to the modifying agents. So what are these modifying agents basically? So we have discussed the disadvantages of the formalin. Yeah, so if you can once again remember those disadvantages of formalin, that is rigidity and interfering with penetration of embalming solution to the tissues, and then hardening of the tissues and drying of the tissues. So all these can be rectified or compensated by these modifying agents. So so they basically delay this firming action which is caused by the formaldehyde, and they also helps in better distribution of embalming solution. So both being the disadvantages of formaldehyde, which are compensated by using this modifying agents. So they delay the firming action, and also helps in the better distribution of embalming solution. So the following the modifying agents that are used, that is the buffers, humectants, anticoagulants, and surfactants. So we're going to discuss briefly about each of it. Firstly, the buffers. Yeah, so the most commonly used buffer is important, and commonly used buffer is the sodium borate. And how does it act, and what is the use of it? So it basically maintains the pH of the tissues in alkaline state, so at an optimal range of about 7.3 to 7.4 for a better action of formaldehyde. So that's what is the use of this buffer. So it maintains the pH in alkaline states for the effective action of formaldehyde. So it can also be it can also be used to reduce the hardening of tissues. Yeah. So that's briefly about the buffers. So the main action of it is to maintain the pH in alkaline state for the effective action of the formaldehyde. So that's about the buffers, which also reduces the hardening of tissues. And the next one is humectants. So as you all know, the humectants, the most widely used and most important humectant is the glycerin. So there are some others as well, that is like sorbitol and all, but this is the widely used one. And how does it act? What is the use of the glycerin? So basically, it's commonly used chemical. Uh, it uh, it basically retains the moisture, so it hydrates the tissues and helps to retains the moisture. So thereby it is so delays the hardening and drying of the tissues. So that's about the humectants. Yeah. So they delay the hardening and the drying of tissues by hydrating and retaining the moisture. But there is one disadvantage of glycerin is that if it is excessively used, it can cause dehydration. So that's about the humectant. So the next modifying agent is here is the anticoagulants. So as we all know, the name itself says they soften the clots. So they loosen and soften the clots. So thereby helping in the better distribution of embalming solution. So the most commonly used anticoagulants are these, that is sodium citrate and sodium oxalate. And the next one, the modifying agent or the surfactants, so which are surface tension reducers. So the commonly used surfactant is the sodium lauryl sulfate, and the main action of it is to reduce the surface tension, thereby again helps in the better distribution of embalming solution. So that's about the modifying agents. So we've discussed briefly about those. So if you can summarize the modifying agents, it includes this buffers and humectants, anticoagulants, and surfactants. Okay. And moving on to the dyes. So the dyes are commonly used in embalming solution. So they can be used in lower amounts or in higher amounts. So lesser amount of dyes are used. So basically to see the distribution of fluid to the superficial tissues. And whereas the higher amounts, if you use it in high quantities, that's basically to color the tissues, especially to color the arterial system. The most commonly used dyes are the eosin, and we have the others as well, but the most commonly used one is eosin. So it can be used in two quantities, that is low quantity is to monitor the distribution of embalming solution to the superficial tissues. If it is used in higher quantities, is basically to color the tissues, especially to the arterial system, so that the structures are distinguished from the others. So that's about the dyes and the odor masking agents. So basically they replace the unpleasant odor of embalming solution. Yeah, so these are the examples of this odor masking agents is benzaldehyde, eucalyptus oil. And diluents, so basically the diluents are the solutions which are used as solvents in which all these chemicals can be dissolved. Yeah, so basically the solvents that are used in embalming solution. So water is the best one. So water is commonly used as the solvent, and alcohol can also be used. Yeah, so that's briefly about the most commonly used embalming chemicals in routine embalming procedures. So if we can summarize, so all those that we discussed. So the first chemical group is the preservative, so which helps in the preservation of tissues. The example and most commonly used one being the formalin. And the second one is the disinfectants, so which helps reduce which prevent the growth of the fungus and bacteria. And the commonly used ones are the alcohols, phenol and thymol. And the next ones are the modifying agents, which includes the buffers. The action of it is to maintain the pH at an alkaline state for the better action of formaldehyde. And the most commonly used buffer is the sodium borate. And the next chemical group next one, the modifying agent is humectant. So which that is the most commonly used one is the glycerin, so which basically hydrates the tissues and retains the moisture, so thereby preventing the hardening and drying of tissues. Yeah. And the next ones are the anticoagulants, that is sodium citrate, so which basically loosens the clots and thereby helps in the better distribution of embalming solution. And then the surfactants, which are surface tension reducers. So most commonly used one being the sodium lauryl sulfate, which also helps in the better distribution of reduce the surface tension and helps in the better distribution of the embalming solution. and the other ones are the dyes, the common used one being the EOS. And then you have agar masking agent, which replaces, which includes benzoaldehyde and eucalyptus oil, and all of this are dissolved in this solvent. So that is water. So that's the summary of this session, and this is my reference book. Thank you all.
A very good morning, one and all. So I'm now to continue with the same session next to Dr. Vijay Kishan about the practices of routine anatomical embalming. So these are the objectives of my session. So we will be discussing about the different types of embalming procedures, what are the various embalming fluids, the brief overview about the different embalming missions, then about the procedure of embalming. Prior to embalming procedure, what are the factors that we have to look into? Pre-embalming assessment, the preparation for the embalming, and during the procedure, what are the components that we go through in the embalming, and after the completion of the procedure, what are the precautions that we need to take. So this is about the definition of the embalming. It's a process of chemically treating the deceased human body to reduce the presence and growth of microorganisms, so thereby delaying the organic decomposition and restore an acceptable physical appearance. So in this embalming that we preserve the human bodies, there are different types. So that is anatomical embalming, funeral embalming, and the embalming that we do for surgical training. So how we arrive at this classification is basically dependent upon the timeline. The kind of the anatomical embalming that we do, the requirement is the structures, the body should be preserved for long term. So there we need little more of rigidity, where the structures can withstand the manipulation for longer duration. Whereas the funeral embalming is very short time period, the requirement. Here the prime importance is given to the preservation of the structure and skin to the near lifelike appearance. So next, about the surgical training, the bodies which we preserve for the purpose of giving surgical treating, it is of intermittent requirement, where like from few weeks to months we want the structures to be preserved in a soft state. So that is about the types of embalming. Next, we will move on to what kind of embalming fluids that we are using to accomplish these different types of embalming. The most common type that we prepare to do the anatomical embalming or the funeral embalming is the arterial embalming fluid, followed by which we may require the cavity embalming for some situations. So then we have a separate fluid with a separate constitution, that is the cavity embalming fluid. Then we have the paint or spray or cloth fluid. Then there is a surface disinfectant fluid. And finally, after completing the procedure of embalming, we immerse the bodies into the tanks, and that composition also is slightly different. So this is the comparison of the embalming fluids. So we have the arterial solution here, where we, for example, for an average 70 kg body, we prepare the solution of around 10 liters, of which 15% of the concentration will be given to the formalin, and nearly 30% is composed of ethanol or methanol, and about 15%, nearly equivalent to the formalin composition, we add the humectant glycerin. We believe that Dr. Vijay has explained about the advantages and uses of the different embalming chemicals. So, and we have the other salts in the same embalming fluid, that is to maintain the pH. We have the sodium borate and we have the sodium lauryl sulfate. If it is not available, we can even use the ordinary detergent powder that we have. If the other salt is not available, we can even use the ordinary common salt that we have. So these are the adaptations that we can do when we have some limited resources. And a pinch of the dye can be used for the arterial solution, and perfume of eucalyptus oil we can use. So this is a concentration that we use for the routine arterial solution. When we prepare such an arterial solution for funeral embalming, where we actually do the venous drainage, that is to let out the excess amount of tissue fluid and the blood and the clots, then we need to really prepare a double the amount of the arterial fluid, wherein the concentration of the ethanol is nearly 24% of the composition. The formalin and glycerin share the equal proportions. When we look at the funeral embalming fluid without the venous drainage, so there also the ethanol is more in quantity compared to the other constituents. So that is about the solutions of the arterial fluids. Now we move on to the cavity solution. So here in the cavity solution, the major composition of this solution is a strong solution of nearly 50% of the solution is made up of formalin. For example, if we are preparing 2 liters of the solution, we add 1 liter of formalin nearly to the cavity solution that we prepare, and the rest of the components are almost the same. When we look at the paint or spray or cloth solution, this is to just to keep the already dissected areas moist. We can apply like a paint over the palm or sole after we complete the dissection to keep it moist. So that time we add more of the humectant, that is to preserve the moisture content of the structures. So 50% of such a solution will be composed of glycerin. Next, we move on to the cadaver immersion or that storage tank solution, where nearly 12 to 15% of the formalin is added. This calculation is given for approximately 2000 liter capacity of the total solution. So we prepare nearly 3/4 of calculate the tank measurement volume totally. we prepare 3/4 of the tank volume of the solution before we immerse the bodies, and after we immerse the bodies, the solution may raise up to cover up the rest of the volume. So next type of fluid that we prepare is a surface disinfectant, which we just apply over the surface of the body. So in which mainly the purpose of disinfection should be salt. So it is primarily composed of ethanol. That is about the fluids. Next we will move on to the different types of embalming machines that is available. The oldest one which we used to have is the manual cans, which are the fluid is injected by means of the gravity method, and a little similar to it is this manual embalming pump, which we give a constant pumps, and the pressure will be maintained inside the can, and that will sustain the flow of the fluid for 3 to 5 minutes. Then after intermittently we need to give some 8 to 10 pumps, and that will maintain the pressure. This need not be kept at a higher level. It can be kept at the level of the body itself. So these two are the manual ones. And next in category is the centrifugal pump, where there will be a swiveling of the fluid inside the can, and that will create a pressure. This will be suitable for a very normal body without any expected complications, where the fluid run will be expected to be a smooth one. So then we can set the rate to a low level from 75 to 125 ml per minute at a low injection pressure. So that is suitable for a body without any anticipated complications. Next type of the embalming machine that most of us would have is the pressure pump, where we set the pressure to nearly 2 to 12 pounds per injection, and that is maintaining the pressure at a very constant level. This is suitable to meet the demands of the body when it is going for decomposed states and also. And the next more superior quality of the machine that we have is the peristaltic pump, where the arteries, the pressure of the fluid injected will not be always very high. It will be able to fluctuate. It will adjust according to the resistance given, so that the danger of rupture of the vessels is not there much with this peristaltic pumps. So these will operate at 20 revolutions per minute for initially for 3 liters we can keep at a lower rate, and then we can increase the revolutions per minute gradually. So these are the different machines that we have in hand. Now, when we have chosen all the fluid type and the machine, how we are going to set the pressure, everything, we also need to look at some of the other criteria before we start the procedure. So what is the condition of the body? What is the age of the patient? If he is older age, there will be a risk of arteriosclerosis, and in that case it is always better to choose the common carotid artery, which is the vessel of very least occurrence of the arteriosclerosis. And we can in children the vessels will be very small and fragile, so we have to choose a smaller caliber metal cannula in such cases. When we have to look at the weight of the individual. In very obese individuals, fatty individuals, we need to inject more amount of a stronger fluid, and we have to the cannula size also needs to be bigger. And when we look at the build of the individual, there is a more muscle composition is there, then we can anticipate a lot of rigor mortis. Then it will be very difficult for us to manipulate the cadavers. So that is things which we have to consider before deciding the composition of the embalming fluid, and then we have to proceed. And depending upon the cause and manner of the death also, when the individual dies in the hospital, whether or not for any case we have to consider it is a high risk case. We have to take all universal precautions to start the embalming process. And if in case of any pre-existing diseases like renal failure, in such cases we need to give a very strong arterial fluids. So all these things we have to keep in mind. And when the body is received 1 or 2 days before, until sometimes due to the unclaimed bodies, until the case is resolved, we keep it in the refrigerator or the freezer. We think that after thawing it will be coming back to the normal state, but there is some amount of false impression that we take about the rigidity of the body, so that we should not get confused. We have to adequately thaw the body, and then we have to start the procedure. So then coming to the damaged vasculature, if in case the person has already underwent some surgeries, the arteries or vessels inside must have been leaking, and so the amount of fluid that we inject may be lost somewhere else. So all these are the assessments that we have to do based upon the history, that we can't take say history, we have to get it from the records or from the attending persons. And also the time delay, the time when the body is received, the time when it is kept into the cold storage, and the time of start of embalming, time of start of thawing, all this details have to be noted in the embalming report, and that which help us will to analyze our performance later. Coming to the preparations, other preparations that we do before the embalming, we have to have a perfect document verification. We need to have a medical certificate of cause of death, and we need to have a police clearance certificate. Be it any kind of body donation that we get, it is always better to have a police clearance certificate, and we need to have the identity proof of the individual whom we receive, and the relatives as well, and their consent. So all these documents have to be ensured correctly received. So then we have to the embalming personnel have to wear a proper protection equipment, and the room in which we are doing should be adequately ventilated, and the exhaust fan should be working in good condition, and there should be proper air exchange. And the metal cannula that we are choosing, we have to look at the size of the cannula. If it is a larger cannula, the pressure and the volume of the fluid that will be released will be proportionately higher enough, and same way when we go for a smaller size cannula, it will be at a streamlined low flow. So that is depending upon the size and volume of the fluid that we require to inject, we can choose the cannula size. So that is about the arterial solution strength that we need to decide before we compose the fluid. When we have the normal bodies who are received appropriately on less than 6 hours, then we go for a mild to moderate strength of arterial solution, where we inject at a very low rate in the beginning and gradually increase the speed of pressure. So when there is situations where the body is refrigerated for more than 12 hours, or there is a profuse whole body edema is there, the obese bodies, in such situations we have to consider increasing the strength of the formalin, so that we are able to effectively percolate till the end of the tissues. And if there is a very much high degree of burns and all that, then we go for a very high strong formalin solutions. So, and in situations where there is extensive liver mortis, profuse entire bodies edematous, anasarca, and when there is a very delayed embalming, then we can consider out of the 10 liters of solution, the last 3 liters of the solution can be given in a stronger strength, very high strength. So these are the precautions that we need to take. Next we will move on to the components of the embalming, that is going serially one after the another. Depending upon the need, we may have the other components or not. So the first one that we do with any kind of an embalming procedure is the vascular embalming. Then followed by vascular embalming, we move on to the cavity embalming, which is not done in most of the anatomical embalmings. It is always preferred in the funeral embalming. And followed by the cavity embalming, we go for the hypodermic injections. So that is to, we will discuss about all these procedures shortly. Then we do go for the surface painting and other auxiliary procedures. When we look at the vascular embalming, we actually have different methods. One is the single point arterial injection, where most commonly preferred vessel is the common carotid artery on the right side. It is the best choice of vessel. But why we are not choosing that vessel and going for femoral artery is, I believe it is only for the purposes of giving that body for the academic or exam purposes for the postgraduate student who is studying with that bodies. It may be for that one reason that we are choosing femoral artery. Otherwise, the common carotid artery is actually more superficially placed. It is most preferred because it is having less incidence of arteriosclerosis. It is in a direct connection with the heart, and it is having a very good performance rate compared to the femoral artery. Then the other types of arterial injections are multi-point injections, under which we have different categories of restricted cervical injection, 6-point injection, and sectional embalming. So single point embalming, when there is no anticipated complications, it's a smoothly running, everything is on time, the body is received with no other evidences of decomposition, the time is maintained properly, then we go for a single point embalming. When there is a delay, there is onset of decomposition, refrigeration, all those things we have to keep in mind and consider at any point of time this resorts of multi-point arterial injections. And followed by the arterial injection, in anatomical embalming we do not do venous drainage, whereas in funeral embalming we do the venous drainage. So in restricted cervical embalming, when we do this, I already told you that it is all in this, wherever we have the complications, we go for this restricted cervical embalming, where we open both the side common carotid arteries and the internal jugular vein on the right side, it will be kept open. The internal jugular vein will be allowing the venous drainage to happen. On the left side, it will be on the right side, the cannula will be inserted towards the heart, and the solution will be injected down towards the heart and the trunk initially, and after completion of embalming of the trunk and the lower half of the body, the needle will be inserted on the left side common carotid artery facing towards the head. So that is the procedure that we follow in the restricted cervical embalming. Next to the 6-point injection, in this we do both the common carotid arteries and axillary arteries and femoral arteries. In this we actually start with the lower limb first. We do the femoral arteries on both the sides, then axillary arteries, and then on the left side common carotid artery, and finally the right side common carotid artery. So this is the way we proceed in the 6-point injection. That is indicated when there is a expected severe decomposition and autopsied bodies. Next is the sectional embalming. When there is inadequate perfusion following a single point injection and there is a decomposition and localized edema or gangrene, ischemia or necrosis, we often choose the sectional embalming. And actually we should never hesitate at any point of time when we do the single point embalming. We have a doubt that the opposite side upper limb or lower limb is not as adequately embalmed compared to this ipsilateral side that we are doing. We should never hesitate, never feel lazy to do the sectional embalming. Then we may not repent later. So that firm decision should be taken. Motivate the embalmers who are doing the procedure to never hesitate to rethink of sectional embalming at any point of time to save the body that is very precious for us. So next is the signs of distribution. We have given the injection, we have to know how well it is distributed. For that we check for the clearance of the lever mortis, that is the reddish discoloration of the skin will be there. It is a normal post-mortem change. That will be slowly clearing when the arterial fluid is replacing the tissues, and the lever mortis will clear from the trunk. Gradually it move towards the head and neck when we do the femoral artery embalming. And the dye will start to appear in the tissues, the use and pinch that we mix. Then the superficial blood vessels will go for dilatation. There will be firming and hardening of the tissues. We can touch and feel, and we can feel the skin is becoming less elastic, and there we can also witness the dryness of the skin. And the fingertips, toes, lips and all will become filled up and rounded, and it will be difficult to manipulate the joints. These are all the signs of distribution of the arterial fluid. And what are all the do's and don'ts when we are trying to measure the effect of arterial fluid injection? So that is, we should always encourage the embalmers to do constant massaging and manipulation of the adjacent joints from proximal to distal. We should actually, it is a very wonderful procedure that is helpful in spreading of the embalming fluid, which we should not feel hesitant to do, because it is one which is going to prevent other complications of inadequate embalming. So these are the simple things which we can always have in our protocol, that we can achieve a very effective embalming. We can do the flexion and extension of the joints while the procedure is going on. So these are the things who the faculty or staff, whoever is in charge of the embalming procedure, we have to ensure, we have to motivate the personnel who is doing the procedure, that the massaging, manipulating joints are flexed, extended, squeezing the lips and eyelids, and all these things which are minor things which will prevent the extended complications in the future. And we have to adjust the pressure and rate of flow according to the evidence of the completion of the arterial injection. We can, if we feel that the ascites fluid is more, or the abdomen is too much bulging, the person is already a hospitalized body, then we can consider in between to drain the fluid from the abdominal cavity or from the thoracic cage. And we can always, at any point of time, never hesitate to add on the sectional embalming. And what are the don'ts that we should keep in mind is, we always traditionally what we do is, we assume 70 kg body, 10 liter, this is the fixed concentration that we mix, formalin, ethanol, the same thing will be written on a chart and that will be mixed. So that we should never do. It should be tailored to the need of the body. When according to the pre-embalming assessment, according to the individual findings, we have to tailor the embalming fluid for a proper preservation. And we should always check for inadequate preservation, and we have to correct it at the earliest possible. And using only single sign, just by the tissues are becoming hardened and raised, we are feeling satisfied that the embalming is adequate. Not that is not enough. We have to at least ensure 3-4 signs the fluid has, the disappearance of the lever martyrs, the whatever signs that we saw just now, all the tissue becoming hardened, the ooze out of the arterial fluid. So all those things we have to see. Nearly 4 to 5 criteria should meet our demands. Then only we should get satisfied about the procedure. What are the problems that we encounter during the arterial injection? So when there is a dehydration, the skin becomes very dry, we have to consider adding more of the glycerin in between. When there is jaundice, we can add more dye. When the tissue firming is not much adequate, we have to increase the strength of the arterial solution. There is a thing called as a shell embalming, that is only superficial tissues will be embalmed by the branches of the main vessel, and it will give a false appearance that nicely the tissue is hardened and raised. Actually, the deeper portion of the limbs or bodies may not be adequately embalmed. So that is one thing we have to see. In such condition, we should consider restricting the venous drainage if it was going on, where there is a loss of more amount of possibility of loss of more amount of arterial fluid that we have injected. Then if we evidence any hypoperfusion in any particular area, I always told that we have to consider the sectional and hypodermal injections. Yes, that is the first thing that we can do, the hypodermal injections, and then we will go for a sectional embalming always. And coming to the distension of the veins, there will be sometimes a very prominence and distension of the facial veins and neck veins, and that time we can allow some venous drainage from the internal jugular vein. So this is the purpose of doing the venous drainage, wherein the fluid will short circuit from arteriole to venule, and it will reach the vein sometimes, and due to the filtration pressure it will reach the interstitial space. We do this venous drainage following arterial injections and funeral embalming, where we don't want the excess amount of blood or clots to be retained in the body. That will disfigure the normal shape and will be more giving more chance of infections and all that. So in that case we do this venous drainage, and the contents of this venous drainage is usually the blood, the clots, interstitial fluid, lymph and arterial solution. I believe this will be covered in detail in the further sessions, so I am skipping on this part. And there are different types of venous drainage. which we do alternatively. We do first 3 liters of arterial injection, then we give some time for the venous drainage and then restart the arterial injection. This is to ensure smooth distribution of the arterial fluid. Otherwise we can do concurrent, where parallelly both are going, or intermittently we can allow the venous drainage to happen for some time and then stop and then restart. So that is, or the different types of venous drainage that we do. So here also there are some do's and don'ts, where the drainage fluid is highly infective. So we have to collect it in a container that should be disinfected with a bleaching powder before we dispose the fluid. And so this is the reason why we restrict drainage, is also one of the reasons during the anatomical embalming. Unnecessarily we are getting exposed to the drainage fluid, which is highly contaminating fluid. Then what are the don'ts that we have to keep in mind is that we should not allow the fluid to pass directly into the sewage, and while washing the drainage we should not use a very high water pressure hose, because it may splatter over the surrounding embalming personnel. So now we are coming to the end of the procedure of injection. So what are the steps that we followed? That we did the arterial embalming. Followed by this, if required, we may do the cavity treatment. Then if there are any invasive devices in that individual who is an hospitalized patient, such devices may be considered to be removed at this stage. And then we consider of doing the hypodermic embalming to compensate for the inadequate embalming at any point, and surface embalming to paint the surface to prevent disinfection. Then we treat the distension of the exposed areas, and certain areas where the lips and eyelids, where there is cracks, exposures, we can do some auxiliary procedures, like we can even apply quick fix and approximate the skin to close the unwanted exposures. And finally we have to do terminal disinfection of the surfaces and areas that we used for the embalming procedure. And post embalming we need to monitor some signs to ensure the good embalming process. And finally we have to assess the cadaver whom we embalmed, and we have to complete the embalming report. So what is the procedure to do the terminal disinfection? The main disinfectant solution that we use is 70% ethanol in 8% formaldehyde. For 45 minutes we have to pour the solution everywhere on the table and we have to leave it for 45 minutes. This solution is also called as a Bard-Parker's solution. And the embalming machine should be thoroughly rinsed with warm water, and it should be kept dry. The embalming table should also be that is what we pour the solution and leave it for some time. The embalming room, everywhere the solution can be sprayed and can be washed with proper soap water solutions. And the instruments also can be kept soaked in this solution in a tray, or if it is a very severely infected bodies, then we should consider soaking it overnight. And after all this disinfection procedure only, the individuals who performed the embalming should remove the PPE. So post embalming, what are the signs of inadequate preservation? If there is a lot of purge, we should try to clear off the purges and close the areas and with this disinfectant solutions. And skin blebs are there, desquamation is there, skin color change is there. If maggots are appearing, then it is always telling us of the inadequacy. So then we should consider again giving the hypodermal injections and the sectional embalming procedures. And we can consider first removing the abdominal intestines, because they are the ones which may not withstand the inadequate preservation for longer duration, and we can try to save as much as possible of the cadaver that we have. In case of a situation where we have to dispose, we can try to preserve the limbs, whatever the possible parts, we can try to preserve them and discard the most contaminated areas alone, decomposed areas alone. So that is the measures that we take. In such case, when we are doing the embalming of the sectional embalming or hypodermic, we have to use a very strong undiluted cavity solution. So that is the thing we have to keep in mind. Other common precautions that we take for safety of the embalming personnel is while we are handling the formaldehyde, we have to wear the kit, PPE kit. Face shield is very, very important to consider because we can anticipate at any time the splashes of the fluids which may have the infectious organisms. And the safety glasses, gloves, ordinary latex gloves may not be serving the purpose. It is always advisable to go for nitrile gloves. If we have only latex, we may use a double gloves with a layer of Vaseline in between. And it's always advisable to wear protectable closed shoes at both the ends. And we have incidences of tuberculosis being transmitted from cadaver to the embalmer, and incidences of the HIV being transferred, which is viable even until 16 days. There are references for this findings, and after even the body is stored at 2 degrees centigrade, after 2 weeks the organism was captured. So, and what is a solution for this is that we can neutralize the infection sites by using 25 percentage of ethanol and 0.5% of formaldehyde. And there are incidences where HIV is reported from bone fragments, brain, bone marrow, spleen, and lymph nodes of the patient at autopsy after 6 days of death also. So we should be very careful and always take universal precautions while we do the procedure. So, and last and most important thing, which many of us may not have kept in mind, is to neutralize the formalin. Whenever we are discarding the solution from the tank, when we are cleaning the tanks, we have to always neutralize the formalin before we dispose of the solution which is there. So that is possible by doing dilution, but it requires an enormous amount of water to be poured into the tank to dilute its strength to 0.01 percentage. So that is, we are wasting too much of water there. So we can consider the chemical treatment of adding sodium sulfate in equal concentrations to the formaldehyde which is already added to the solution, and also hydrogen peroxide and sodium hydroxide can be considered. The formaldehyde tolerant bacteria may be considered adding to it, and some activated sludge. So these are the ways to dispose the formalin, which I request everyone to keep in mind to save our environment. So these are my references. I would like to conclude saying that a famous quote from Vince Lombardi about the perseverance: the difference between a successful person and others is not a lack of strength or lack of knowledge, but rather a lack of will. We should be very determined about the achievement of effective embalming or receiving cadavers or whatever actions that we are intended to do in our service. Otherwise, we can never reach the success. The learning is always happening throughout the journey, but always there should be a strong determination and perseverance to achieve our targets. Thank you very much for the opportunity. About the reference for composition of the embalming fluid. So actually I shared my references at the end. It is from the textbook of Embalming and Whole Body Donation, a Practical Guide by Dr. Rajshekhar SSN. Thank you.
Thank you, ma'am and sir, for a well-informative lectures. Now I request Dr. Sarnya ma'am to introduce our esteemed speaker, Dr. Sudhaseshan ma'am, who has joined us today to share her expertise on the topic.
Uh, Good morning, madam. Good morning, all. So, before I start to introduce Madam Dr. Sudha Seshen, actually, I want to ask the audience. Suppose if you are asked a question, who's a best cricket player in the olden times, whether it is Kapil Dev or Sunil Gavaskar, so what would you say? You can put in the chat box. Whereas, if you want to know who is the best all-rounder in our field of medical expertise, without any doubt, in a fraction of second, I would say it is our esteemed Dr. Sudha Seshen, madam. So, with a very proud privilege, I am introducing madam here today. So, Madam is currently working as a director of Sastra University, Chennai. She is a vice chairperson of Central Institute of Classical Tamil, Chennai, and she is a former vice chancellor of Tamil Nadu Dr. MGR Medical University, State Medical University of Tamil Nadu. So she is a very well-renowned figure in healthcare, medical education, medical administration, literature, and spirituality. As an academician and administrator, Madam held a lot of prestigious administrative positions in her career, and she is a recipient of Best Administrator Award by MGR Medical University. And she has authored scholarly articles for Science Encyclopedia of Tamil University. She is a multifaceted personality, her interests ranging from ancient Bharatiya wisdom to modern literature. From science to spirituality, history to hagiography, tradition to transformation, she is an exceptional speaker and freelance writer and translator. Above all, Madam always continues as a lifelong student. So, there is a famous quote by Quincy Adams, that is, if your actions inspire to dream others to dream more, learn more, do more, or become more, then you are a leader. Madam, you are my inspiration. In the beginning of my career, I first met you as a PG student when you conducted the quiz competition. That was my first interaction with you, madam. And I was one of the prize winners in that event. And that is when you were always my inspiration, and not only to me, to entire the anatomists in this country. You are a great inspiration, madam. So we welcome you to give your expertise, share your expertise in the lecture of topic evolution of cadaver procurement from past to present. Welcome you, madam. Thank you.
Good morning. And thank you very much for those wonderful words. I'm a little too elated by your lovely words, and thanks a lot. Let me try sharing my screen now. Is that visible? Can someone tell me if it's visible?
Sorry. Hello. Sorry, ma'am, I couldn't hear.
Hello, check.
Yes.
Yeah, it's visible?
Yes, ma'am, it is visible.
Okay. Thank you. And thank you once again for a wonderful opportunity to share a few thoughts. Much has been told about the embalming procedures. We heard Dr. Saranya and Dr. Vijay Kishan telling us many details. Now, for those of you who might be a little unversed, the last 3 decades, there had been an enormous growth in the area of embalming. Various embalming procedures have come into play. I say this because 3 decades ago, funeral embalming or transport embalming, as we would call, when bodies need to be airlifted or transported across towns, were all not heard of. We only had anatomical embalming which was required in the anatomy departments for the preservation of the bodies for the sake of our study, research, and dissection. So many of the details, many of the newer fluids which have come into existence, fluids which can be used in funeral embalming and in transport embalming, are all newer ones, and innovations keep going alongside. However, if all this embalming needs to be learnt and advanced, it is also required that we know something about procuring the cadaver. And I have been given the pleasant task of sharing opinions and ideas and information about cadaver procurement from the past to the present. There is a well known Latin statement, mortuae vivos docent, which translated into English will say, the dead teach the living. In fact, this is not only the philosophy of anatomy or philosophy of an anatomist, but it is also the philosophy of life itself. The dead teach the living. In other words, we learn several things from the past. So I would like to embark on this journey today with that sentiment in mind, mortuae vivos docet. We are here to think about cadaver study, that part of anatomy which is contributed to by cadaver study, and how did this cadaver study come into existence? There were two things, two independent reasons assigned to studying the cadaver. Today we are talking about procuring a cadaver, preserving a cadaver, and then studying, dissecting, and researching on it. But please remember, one of the early uses of a cadaver was not to study it, but then to preserve it. So if you hear cadaver documentation and cadaver information which come from the Egyptian papyri, that probably indicates because of the elaborate Egyptian burial rituals, they wanted to keep the cadavers preserved, keep them safe underneath in the pyramids and so on. So they studied many things about the cadaver so that they could preserve them better. Of course, after the Egyptian period came the necessity to know the body, to know the human body proper, the human body and its intricacies, and thereby developed the knowledge of the cadaver or the entire discipline of what can be called cadaver study. Somewhere between the third millennium before the Common Era and the 2nd century Common Era, Egyptian people seem to have studied human anatomy more, much more than the rest of the world. And we also have written records. In fact, because of these records, we get information on several body parts, most of them being external. Mummification rituals, preserving them. It doesn't matter if the internal organs are shrunk, but then the entire body needs to be preserved and kept with a presentable position. So it is the external parts which were more identified and labeled, and not much of importance were given to the internal structures and organs. And this is what I told you earlier. These are evidenced by the Ebers papyri, Edwin Smith papyri, the ritual of embalming. We have papyral documents which talk about embalming and how embalming is done. But then the embalming which is referred to in this ritual is more of mummification and not what the embalming that we can visualized today. There is a mention of a word metu in the Ebers papyri, and the number of metu in a human body is 52. And it says these metus run to different parts of the head. What exactly is meant by the metu is not clearly known. It could probably mean the vessels, the nerves, some kind of channels which go up. Maybe they could mean both the vessels and the nerves also. The Edwin Smith papyri identifies body parts which are internal too, especially relating to the brain, the meninges, and also has a mention of the cerebrospinal fluid. But these are all related to preservation of the body, and that is where the initial anatomical studies started. Subsequently, there was emphasis on animal dissections. The human body cannot be subjected to experimentation. So, animal bodies were dissected. Aristotle was of the opinion that animals will have to be dissected by people who provide health care, and animal dissections were favored. There was also a time subsequent to Aristotle, a time of vivisection. And why have I marked it with question marks? Vivisection, most of you will know, is a kind of a dissection or a procedure done on an animal body as we think of it today. The animal is alive. The kind of animal experiments that some of our physiology labs have, the frog being experimented upon, some other smaller animals and creatures being experimented upon, where the animals are alive. That was something to do with the animal studies. Sometimes people resorted to dissecting dead animals. And I have heard that even in Madras Medical College, in the years 1950s and 1960s, there were dissections of dead animals and birds, animals which had fallen dead, especially crow and other birds which had fallen dead, were taken up by the anatomists for further study so that they could compare and find out, replenish, and embellish their knowledge of human anatomy also. But this vivisection that I'm talking about is not related to animals alone. There was a time in history, it is presumed that morbid prisoners or people who were condemned were subjected to some kind of a live dissection. They were alive and dissections were carried out on them. The documents are very poor in this regard. There are differences of opinions here. It is said that Herophilus, who lived sometime in the 3rd century before the Common Era, performed some vivisections. But Herophilus is also dubbed the father of anatomy. We do find a lot of information from Herophilus' work. He vividly describes several organs, several structures. It can also be said from our knowledge that Herophilus probably did not do vivisections, but only kind of performed dissections on dead cadavers. The reason I say this is Herophilus has recorded that the arteries or the blood vessels, as he called them, do not have any blood inside. And if he had done a living dissection, there would have been some kind of blood flowing in, and he would not have recorded so. So it is presumed by the research circles that Herophilus did not do a vivisection, but then did some kind of cadaver dissection. But how he procured the cadavers and what was the rule is not very clearly known. Subsequently, both animal dissections and vivisections were used, and we come to the time of Galen, who lived at a time were probably both animal sections and VV sections. I'm sorry, there is an error in the display that you see. Galen lived in the 2nd century Common Era, and please disregard the time that is given there. And Galen studied the human cadavers which were available, like, people who are dead and cadavers were lying there. Galen had taken some kind of extra permission that he could study them. And here we find a kind of a picture, a painting, which indicates that he was studying the human skeleton. Then came a time, don't procure a cadaver, but then study surgical procedures which are happening on individuals. Slowly, we move to the time around the 12th century. See that Egyptian period, cadavers were studied, and before Common Era, cadavers, vivisections, animal studies, slowly it became a kind of a restricted environment around the 12th century where dismemberment of body parts was forbidden, dissection was banned. So you find a time where cadavers could not be studied, and people resorted, even credited anatomists and physicians resorted to studying whatever Galen had stated. If we go back and see, Galen kind of had an advantage because he served as the chief physician of gladiators. So he studied the wounds. Gladiators injured themselves and he studied the wounds. He also studied animals like oxen, pigs, apes, and so on. And he has given a large body of text which runs for about 22 volumes. And we can say of these 22 volumes, two are very important. One is called On Anatomical Procedure. The other one is called On the Uses of the Parts of the Body. So, people until 12th century resorted to whatever Galen had given in the 2nd century. For about 10 centuries, there was not much of dissection, but it was only Galen's anatomy which ruled the roost. There were errors in Galen's anatomy. He kind of said the circulatory system is open ended, blood flows into the body and then gets rejuvenated, it is reproduced in the liver. And arteries, as I told you, contain air. The heart is a warm area. But then he also stated the lungs are the organs which cool the body, and they also remove the sooty waste. So there were some errors, but then there were also facts which can be related even today. In between the 2nd and the 12th century, there were also certain procedures which were adopted too, and those procedures relate to what is called evisceration. Dr. Saranya was talking about cavity embalming, but then much before, there was a procedure called evisceration where the internal structures, internal organs were all completely removed, and some kind of preservative fluid was filled into the body cavity. And this was needed when the dead bodies of kings and big people who were at the higher levels of the hierarchy, when those bodies were kept in place, they were kept for respect's sake or they were kept as exhibits, then there was a necessity to eviscerate and then put in a lot of fluid and keep that exposed. So until about the 12th century, we find that there were lots of fluctuations. But in between, in the 10th century, we also see somewhere in the Turkish land, in the areas of Turkey, we find certain anatomists in Turkey and Persia, Abu Bakr al-Razi, who's usually called Rhasis, and there is a well-documented anatomy work by Abu Bakr, which is called the Kitab al-Mansuri. And he had studied the anatomy of human beings with the help of cadaveric dissections. So slowly we come to the time between 12th and 16th century. Dissections were performed, dissections were permitted in dead bodies, but then it was also that there was public and open viewing of dissection. Medical students were mandated to learn anatomy. There were certain emperors who passed rules that people who take up medicine should take courses on human anatomy and surgery. Emperor Frederick II passed a rule like that. Leonardo da Vinci dissected around 30 human specimens until Pope Leo X is supposed to have forced him to stop. You find Leonardo da Vinci recording on the anatomy of the upper limb. And then people were also permitted to watch dissections, and one famous uh, area in this regard is where people were permitted to watch Vesalius doing the dissection at times, and they also had times to interact with the animal corpse. Vesalius' anatomy work, the well credited and the well known De Humani Corporis Fabrica, it includes a detailed series of explanation and vivid drawings of the anatomical parts, and the book is available even today. So slowly we find public viewing of dissection was permitted, and this is the very famous dissection hall of Padua. In Padua, the dissection hall was a circular structure. The body to be dissected would be placed on a table right inside the well of the dissection hall, and observers, students were all permitted to sit on the different tiers. They could sit there and view the dissection. Usually, it will not be the professor who would do the dissection, but he would stand somewhere and lecture about the structures and the parts, and he would permit one of his assistants to perform the dissection. So, dissection theaters, after Padua, the dissection theaters became a popular form for anatomical teaching. So, you did not have to procure cadavers at every level or every institution. People from different parts of Europe were all sent to Padua, and they learnt anatomy at Padua. It was a kind of centralization, and the participants were all fascinated by the corporeal display. And students and observers would stand around the table in a circular stadium like arena, and a close up view of this arena that you find. And this Padua system flourished not only across Europe, but then you find even in India, some of the early dissection halls during the colonial period, including the one that was built in Bombay and one that was built in Madras Medical College, they were replicas of this Padua dissection hall with a well deep inside and kind of, circular arena for people to view from. By early 16th century, there was also the flip side of it. There was a negative side on the procurement of cadavers. People resorted to different other means. Some kind of abuses did happen, primarily because the demand increased and people wanted to procure cadavers by whatever means they could. And by early 16th century, there were certain controversies, but one controversy less individual suffered a controversy. A Spanish physician by name Miguel Servito, or Michael Servines, as the anglicized name goes, he published some works from dissections which were done after appropriate permissions. But then he was condemned for publishing his work from dissections. He was condemned in France. He ran from France, he fled France and went to Geneva, but then he was traced to Geneva and he was burnt, burnt alive with his books of anatomy and books of theology. He was also a theologist and he was burnt at stakes. So by 16th century, cadaver procurement was one side favored, on the other side, there were issues related. By the 17th and 18th century, only certified anatomists were all permitted, they were allotted to perform dissections, and they could only do dissections on an annual basis, only once a year, which means cadaver procurement had to be restricted. And an admission fee was charged. So if I am the qualified anatomist, I am permitted, I would do a dissection, but then I would throw it open for all of you to come and see at a particular fee. So thereby, once again, on one side, there was permitted dissection. On the other side, scarcity, demand increased, and clashes between permitted establishments. If I was permitted and somebody else was permitted, there was some kind of a clash between the two of us. And each one of us would kind of backstab the other. So all this led to some legalization. As we always say, necessity is the mother of invention. The necessity to legalize certain procedures, legalize so that people do not steal cadavers, people do not rob the burial grounds of the cadavers, people do not kill people to do a dissection. So thereby, in 1752 in England, the Murder Act was passed, and this Murder Act allowed medical schools to legally dissect bodies of executed murderers. Not people who are living, but then they had already been executed. And once the capital punishment was given, post capital punishment, their bodies could be utilized for dissection. And you know what? On the other side, something else happened. To increase the number of such cadavers, post execution cadavers, the crimes in which hanging was a punishment was also increased. Certain crimes which were not given hanging punishment in the earlier times were now included in the ambit of hanging, and the number of executed murderers increased. On the other side, there was still body snatching and anatomy murders. Murders which happened so that people, people who are invalid or people who could not move much or very sick persons or people who were very old were all killed so that somebody could do a dissection and learn. A kind of a human guinea pig experimentation. And this led to some kind of commercialization. There were people who were called resurrectionists. They called themselves resurrectionists. They were third party resurrectionists. You know what happened? People would kind of resurrect and steal a body, rob a body from the burial ground. And that would change hands. A third party person would keep that body and then sell it to one person who wants to do the dissection. So you have somebody taking it from the burial ground, somebody else selling it. And our very famous John Hunter, many of you would remember Hunter for the various contributions that he had done to anatomy, but then John Hunter paid for a regular supply of cadavers to his anatomy school. Many European countries, because of this, passed legislation similar to the Murder Act of England. So they wanted to have a kind of a legislation so that body procurement became legal and properly handled. Countries now allowed institutions to use unclaimed bodies. This is where the concept of unclaimed bodies came in. When there was a shortage of bodies of criminals, executed people, executed murderers, and executed prisoners, and on the other side, to curb illegal procurement of cadavers, there was some kind of legalization by saying unclaimed bodies can also be utilized for dissection procedures. So, unclaimed bodies of paupers, prison inmates, people in psychiatric asylum, charitable hospitals, people who were, kind of, they had no one else. They were practically orphaned and they were in charitable hospitals and they died. Such unclaimed bodies could be utilized for dissection. In France and Paris, a law of 1794 was passed, and this supplemented medical schools with bodies for anatomical dissection. So you can see, end of 18th century to early 19th century, all these laws were being passed. And in subsequent times, what happened? The British Parliament passed what is called the Anatomy Act of 1832. And this act finally provided for appropriate, adequate, and legitimate supply of bodies by allotting legal dissection of executed murderers. At the same time, societal opinion was on the other side. If one's body was dissected, it was seen as a punishment worse than death. And a very common adage in the European countries in those times came into existence. If you stole a pig, you were hung. If you killed a man, you were hung and then dissected. So, dissection was considered a kind of a punishment that can be given to the particular cadaver. On the other hand, demand increased. Some anatomists resorted to dissecting their own family members when they died. And they also resorted to stealing the bodies of their family members from the graves. In the United States, the Anatomy Act, which was passed in England later, Act of 1832, but then in the United States, Anatomy Act was passed in 1831 because dissections of human cadavers commenced in Philadelphia sometime in 1762. So by early 19th century, all these controversies were kind of put down. There was regulated use of dissections. Women who were not permitted into the medical schools in Britain at that time were allowed to witness dissections. Museum techniques grew up. Comparative dissections, animal dissections also increased. So some kind of via media was struck. Later, other advancements helped. And when people like William Harvey, discovered the circulation, he also injected colored fluids into the circulatory structures. We heard Dr. Saranya talking about injecting fluids. Now, we can say works of people like William Harvey kind of gave the anatomists a better view, a wider view, not only to procure cadavers, but also to utilize the cadavers in a better way. Animal preservation techniques also helped, as on one side, the human anatomists were trying to study, there were also animal anatomists who were trying to preserve the bodies of the animals. When you go to the zoo or when you go to a museum, you find that there are certain animal bodies which are preserved. But then there is a lot of difference between the preservation that human bodies undergo and the animal bodies undergo. You will find animal bodies have the external appearance, the exterior is the same. It's only the skin and the superficial tissues which are retained. The rest of the cavity is all kind of stuffed with some kind of artificial material. So such a principle is what is called taxidermy. However, when animal anatomists performed taxidermy, human anatomists could learn something and could retrieve parts of the cadaver and preserve them and study them. Now, with that being the world scenario, let's see what happened in our own country and what is currently happening. We have any number of examples in the Indian Puranas where donating a body, today we talk in terms of voluntary body donation, but then donating a body or a body part was encouraged and followed. We have this famous episode about sage Dadichi, who obviously donated his body so that his ribs could be retrieved and the Vajrayudha of Devendra could be, fashioned from Dadichi's ribs. Dadichi parted with his ribs, and to give his ribs, he had to donate himself. The government of India released a stamp on Maharishi Dadichi in the year 1988. Donating body parts, you have the other famous example of Emperor Sibi of the Ikshvaku clan, who gave parts of his body for the sake of saving a pigeon. And of course, in South, we have this famous example of Kannappar, who was originally called Tinnan. Now, I'm not trying to say that he donated, but then there is a concept on which he acted. He said, "Oonukku oon." Freely translated into English, it'll mean a body part for another body part. Like, if someone's eye had suffered, remove the eye from somebody else and keep it there, that disease will be cured. Now, this custom was prevalent in the Aboriginal tribes and in some of the hunter clans. So, if some area was diseased, they would remove the same body part from elsewhere and put it in, which means they had some knowledge of anatomy and some knowledge of donation of a body part. In the Ramayana, we have the instance of the body of Emperor Dasharatha, who died, being preserved in an oil tank. As vivid as what Dr. Saranya described, like, you have a preservation tank, you pour so much of, so many liters of fluid and all that, we find this instance where Dasharatha's body was put in a Taila Kadal, a sea of embalming fluid or some kind of anointment fluid. What about the early Indian medical men? We have instances of cadaver dissection quoted even in the Sushruta Samhita. And there's a description of how that cadaver should be. I would just give it very briefly. Samastagatram, the cadaver should be good, fleshy, free of any disease. Avishopahatam, it should not have died, the person should not have died of poisoning. Adirga Vyadi Pititam, the individual should not have had a chronic disease. Avarsha Shatatikam, should not be over 100 years of age, which means you can dissect a body if you get a dead body of a person who had died less than 100 years of age, and then the fecal matter should be removed and all that, and the cadaver should be kept in flowing water. It should not go away in the river, so keep it tied up to an iron railing, cover it with herbs, keep in shadow. Some of you might remember this shadow becomes important because brain tissue or neurological tissue, if it is exposed to sunlight, would start darkening. This is what we've seen in our experience, and this can be related to what the Sushruta Samhita says. And after dissection, keep it immersed in water if you want to dispose away the dissected parts so that it could putrefy, and then you can dispose appropriately. And the dissection should commence after the 7th day, after you procure the cadaver. Put in herbs, preserve it and all that. And so slow scraping method can be done and preserve the internal structures in appropriate containers. And this was our early medical men. And when we come to the colonial period, whatever British Act was adapted in England was also adapted in India. Information about unclaimed bodies was taken up for dissection. There were storage difficulties. We have records where the medical men of those years have recorded that they could not store a body for more than 7 days or 15 days. And they kind of pulled in the dissection time. They said the medical students can do the dissection when they get an appropriate body. Until then, they have to wait, they read the theory or do something else. But then dissections will be done within a week's time or within a 10-day window period. And because they had difficulty in preserving the bodies and getting the bodies, they said the dissection laboratories should be located away from the mainstream hospital. It should not be closer to the hospital where the patients could see the dead body, and it should be closer to disposal area. It should be closer to the railway track or closer to some other area where waste is being disposed. After 1947, the independent states of India thought of legalizing cadaver procurement because the British Act, it got annulled once the British people left India. So we had to formulate our own acts. The two early anatomy acts which came into existence are the Bombay Anatomy Act of 1949, very quickly followed by the Madras Anatomy Act of 1951. Bombay was a larger presidency, so what emerged later? There was a Vidarbha Act, there was a Saurashtrian Act, there was a Bombay Act, but then all these subsequently got reformulated when the Maharashtra Act came into existence, Gujarat Act, and all that got separated when the linguistic division of the states got established. Similarly, the Madras Anatomy Act originally covered the states what we call as Tamil Nadu, Andhra, Telangana today, and including parts of Kerala. But subsequently, Madras Anatomy Act became the Tamil Nadu Anatomy Act when Tamil Nadu emerged as a state, and the Kerala and Karnataka Acts also came into existence. These acts in general said unclaimed bodies to be used for dissection, and specific institutions only were permitted to do the dissection. So the other state acts followed. Delhi came in 1953, UP 56, Kerala, Karnataka in 57, until Orissa in 75. And of course, some other acts have come after 1975 until about 2023. All these acts aim to provide unclaimed bodies to medical and teaching institutions for anatomical examination, dissection, and related purposes. Now, when I say related purpose, I have something to explain there, which we will see a little later. I'm just keeping it, just mark it. Related purpose is something that we will see later. And these acts typically defined the approved institution as a hospital or a medical or teaching institution, and these were approved by the respective state governments. And in general, unclaimed will mean bodies not claimed by near relatives within a prescribed time frame, 10 days or 15 days. Now, when I said other purposes, here related purposes, some of these acts provide for therapeutic use. What do you mean by saying therapeutic use? See, before the Transplantation Act came, from the cadaver, if the cadaver is within 6 hours of death, some parts, including the cornea, could be retrieved and used for therapy for somebody else. So these were the therapeutic uses. Some bits of tissues can be removed, not only cornea, but from some other organs too. So some of these acts provided for the therapeutic use. Some of these acts have not covered voluntary body donation until now. Amendments or modifications have not happened. Earlier, there was nothing called voluntary body donation. There had even been court cases. Two predominant court cases can be quoted. One was from the state of Tamil Nadu, where a particular individual approached the High Court. He was denied permission in the High Court, and then he went to the Supreme Court, wherein also he was denied permission. The reason he insisted a particular hospital and a teaching medical college near his residence to accept his body. But then the people in the hospital and the medical college said, we have no facilities and we have not been legally approved for this, so we will not take the body. So he approached the court, but since there was no appropriate law, then uh, he could not succeed in his demand, and the court said no. If the institution is willing to accept it, it's fine. If they have no means to accept or they have no facilities, then you cannot force them. And when Mr. Shatrughan Sinha was the Union Minister for Health, there were certain moves in the Parliament of India so that certain acts could be amended and brought in. But then there was no uniformity, so it got stalled. The definition of the institution is also a kind of variation, wherein which exactly is the institution? A teaching medical hospital, a teaching medical college. But then, when different paramedical, allied health, and Indian systems of medicine like Siddha, Ayurveda, and all emerged, those institutions were not covered initially. Now we have some of these acts which cover those institutions. In some states, they still are not covered. So, again, the definition of the institution is a matter of variation. So, you find amongst the state acts, there are lots of variations, and these variations need to be kind of addressed. So, what are the challenges that we face today in cadaver procurement? If voluntary donation is not covered, you will remember Dr. Saranya saying, have your documentation done properly, check, and also have a police report. This police report documentation may not be required in all the states. I would only say people who are involved, please check your own state act. In Tamil Nadu, voluntary body donation is kind of covered, and there are institutions which are given permission to accept the body donation without any kind of police report or anything. But Karaikal is a different territory, it is not Tamil Nadu territory. Similarly, there could be other areas where in that state act, voluntary donation may not be covered. I told you about two court cases. One I narrated, the other one I did not. In Delhi area, there was a person who went to the court and wanted to donate his body. He approached the court for appropriate orders, but then the Delhi Act did not cover voluntary body donation, so he could not be given that order then. Now amendments are happening in different acts. I'm not giving you the details of the current amendments here. It is for you to find out what is the current amendment in your location, region, or area. If the voluntary donation is not covered, there comes challenge number one. The prospective donor, in case I want to donate my body after death, if I'm willing to donate, then I would have to take the body donation form, which is available in the corresponding area, the medical college or the institution. I'll have to file an affidavit that I'm willing to be a cadaver donor. And then if I have legal hairs, I will have to obtain a legal hair certificate, kind of appraise my son, spouse, or daughter to be prepared to donate my body. And then they also have to give a no objection certificate. With all these documents, I can go and register that I'm willing to be a donor. But then this is a very cumbersome procedure. Getting revenue documents like legal hair certificate will be difficult when someone is alive. Getting a legal hair certificate, it is possible, but still it is a very cumbersome procedure. And if people are of the elderly age group, they would not want to go here, there, run from pillar to post and do all this. And for the relative of the deceased, supposing I die, my relative wants to donate because I had a will. I have told them, I have not recorded a will, but then I've told that my body should be given to some institution. They still will have to obtain a legal heir certificate and then give a no objection. Supposing there are 3 sons and 3 daughters, all of them will have to state, and someone could be living abroad and someone will not be willing to give a no objection, then all this becomes, they are also grieving at that point of time. During grief, You cannot insist on certain documents. It is time consuming. So, with the body lying there, they would not want to spend so much of time and all the sentiments that go along with. So, if voluntary body donation is not covered in the Act, it becomes a major challenge, and running awareness programs of voluntary body donation will become difficult in that area. Similarly, the Act says near relative. Near relative will have to sign, or near relative will have to say no objection. Now, who is a near relative? There are acts which subscribe to the spouse being a near relative, relationship because of marriage. But then there are also acts which say only a blood relative. So, there again, if the son or the daughter are elsewhere in a different country, there could be problems. And who can donate and who can withdraw? Supposing the child, the son or the daughter, is of a minor age, will they be permitted to donate, or will they be permitted to withdraw the donation if I had recorded a donation? All these become legal entanglements. And the time period of being unclaimed, how long can you say somebody is unclaimed? Of course, this problem is getting solved on its own. No longer do we get unclaimed bodies. I remember when I was in the medical school as an undergraduate student, there was something called unclaimed. When I was a postgraduate student learning all the nuances of embalming in anatomy, unclaimed bodies could be obtained. But slowly that has come down. When I left Madras Medical College, the inflow of unclaimed was practically zero for years together. The reason, with all the communication that goes on, you have your cell phones, you have your gadgets. See, those days when somebody came all the way from Andhra or Telangana to Chennai to get treated, they would have just told their people and come here, got admitted, probably died in the hospital. By the time they could be traced, the relatives could be traced and information sent, it would be days together. And relatives may not be able to come from rural area. But today you have lots of communication, you have transport facilities. So practically this unclaimed is becoming something which is non-existent. Ambiguity in the definition of the approved institution. As I told you, some of the acts just say a teaching medical college of that particular area, or they specify the name. The Madras Anatomy Act, when it came into existence, had the name of only two medical colleges, Madras Medical College and Andhra Medical College. Subsequently, Stanley was included. Subsequently, other colleges were included. Amendments went on. So the provisions of the act gets expanded. But this may not happen in certain regions. So there could be troubles. Similarly, there could be troubles in getting the Ayurveda, Siddha institutions into the ambit, some of the allied health institutions into the ambit. All this needs to be addressed in that particular act, in that particular region, in that particular location. Now, there are some questions we still have. With all these acts coming into existence, we still have some questions. And as anatomists, probably these are questions that each one of us will have to try to answer and find solutions. Is therapeutic tissue coverage required now? There is no need for cornea to be taken. Like, you don't have to have a separate provision in the Anatomy Act, because Transplant of Human Organs and Tissues Act has come into existence. So that will cover the therapeutic use, and this can cover only the anatomy use in the department, or for the sake of transport, or for the sake of funeral embalming. So that part of it need not be included in the act, that can be amended. Jurisdictional area. Now, this is one problem which I have faced as Director Anatomy, Madras Medical College. Someone registers with me with Madras Medical College. We have a registration process. There is a very, very vibrant process, vibrant voluntary body donation awareness program. So they come and register. We give them the registration card. They have the registration number. But then that person, usually people above 50, and they go somewhere, they go to their daughter's place, son's place, elsewhere in some other state, and happen to die there. will this card become eligible there? Now, this is something that anatomists will have to think of. Like, you cannot say you registered there, so go there and die. Now, these are things which we need to address and kind of make some appropriate amendments. Transport from a remote or donor dwell location. Similarly, somebody registers at Chennai and then they go to some remote village and live. There can be a possibility that they go to the village, their own native village, and live there and die there. Now, who's going to transport the body? As of now, many institutions say you bring the body to us and then we'll accept. We may not be able to transport 500 kilometers, 1,000 kilometers, and so on. So, this also needs to be addressed. If we want a very vibrant voluntary body donation program, then all these questions need to be addressed. Prevention of abuse and misuse. When you say on one side voluntary body donation is an advantage, on the other side, an old person, children are not living in this country, they are abroad. And this person, probably the wife died or the husband died, a single person, now living in some organization, in some home or something. What is the guarantee that this person may not be abused and killed? And, these are issues. They may be hard to think of. We may not find it very palatable, but this can happen because your embalming can mimic, can completely mask any other sign. There are situations where some of my colleagues have received bodies with some kind of a mark in the neck, probably hanging, or some kind of strangulation. So these have happened, and we need to look into abuse, misuse, precautions to be taken. Time duration for unclaimed. How long do we wait? If there is an unclaimed body, how long do we wait? Can we store in the anatomy department, keep in frozen storage, and probably if the relatives comes, and if the relatives comes, what kind of documents should they bring in? Now, all these are medico legal issues which need to be looked into. Utilization in the anatomy department, appropriate utilization, not only plain utilization, but appropriate utilization. The olden unwritten law was keep the body in storage for some time, do not touch the body for about 6 months, not only because there can be some medical legal issues, but also because even if there was no medical legal issue, the individual who's using it in the anatomy department, say, I'm the professor, Saranya is with me, or someone else of you is with me. No, we should not remember the individual or carry memories of that individual with us. So, for this memory to fade off, you just allow dormancy for 6 months. By then, the body is someone else's body. You don't have a sentiment attached there. So that sentiment will have to be, this is not becoming neutral, this is not becoming dry, but then, the kind of sentiment that can go along is a kind of, moving that sentiment is a kind of respect that we give to that individual. I remember when we were in medical school, we were told not to wear nail polish, not to wear flowers, tie up our hair, and boys were told not to wear a full sleeved shirt because you can soil the sleeve with all that embalming fluid and all that. And we were supposed to kind of treat that cadaver, which happens even today by cadaver programs. But then that existed. We were told don't wear nail polish. It is like someone, your grandfather or your great grandfather had passed away, and you'll have to give respect. So utilization will have to have all its respect when we utilize in the anatomy department. Final disposal, I just want to say one single word here, final disposal will have to be collectively thought of and addressed. But then I remember Dr. Saranya mentioning one thing. She said the drainage should not join the general sewerage. I remember when we inspected anatomy departments before approving the departments, there used to be a system where the drainage of the anatomy department should not pollute any other drainage system or should not pollute any other water source or water line. This used to be checked during the inspection time itself. Religious and traditional beliefs also need to be addressed. They are not they are not a major legal impediment. There is nothing which impedes voluntary body donation here, but then there can be local traditional beliefs. There can be that, somebody who does the last rites may get a larger share in what the individual has left. So that person, that son or daughter would say, no, 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 I would not want to donate this body because I have to perform the last rites. So wherein we can kind of innovate and adapt, perform the last rite, after that the body can be given. So all this needs to be looked in. And one other word of caution in voluntary body donation: when someone comes and donates the body, now please take care to note what could have happened inside. I remember we had a cadaver workshop in Madras Medical College, a fresh body which we had kept on fresh storage, and within about 72 hours, we had a wonderful workshop on perineum. Gynecology people wanted to do a workshop on perineum and, of course, on hysterectomy procedures. So when they started the procedure, everyone was in for a shock because that was the body of a lady who had undergone hysterectomy. So when they tried, the uterus was missing. And we do not know when somebody donates, we do not even know, we do not record these questions. And somebody donates after chemotherapy. There could be some kind of malalignment of several structures and adhesions and all that. So please be prepared in voluntary body donation. There could be modified or changed anatomy, and this also needs to be addressed collectively by all the anatomists. So when you require appropriate amendments, I've just floated some of the questions. These are questions which need to be given a solution, for which we need to have collective work and collective responsibility. Not one individual thinking about it. Sit down, have a discussion of this kind as we have today and tomorrow, maybe work out a solution, and then see that solution is implemented. Thank you very much for a wonderful opportunity, and all the best to all the participants.
Thank you so much, ma'am, for enlightening us with your vast, informative, and a very interesting session on evolution of procurement and embalming of cadavers. Thank you, ma'am, for addressing important issues related to body donation and guiding us with your expertise. Thank you, ma'am. Kindly accept the memento and the certificate of the session as a token of gratitude, ma'am. Now, I request Dr. Vijay Kishan sir to introduce our next speaker, Dr. Deepak Vinod Francis sir.
So I welcome Professor Dr. Deepak Vinod Francis sir. Sir is currently Professor of Anatomy, Christian Medical College, Vellore, with an experience over 17 years in teaching undergraduate and postgraduate students, and with expertise in cadaver skill training for surgical disciplines. And sir's area of interest in research includes plastination and tissue preservation, cartilage repair using stem cells and contraprogenitors, innovations in histology and virtual microscopy. And sir has authored over 20 plus peer-reviewed articles in high-impact journals, and sir is also speaker in national and international conferences. And sir is currently working on exploring formalin alternatives and congenital anomaly pathogenesis. And sir is going to talk on the topic the embalmer's challenge managing high-risk cases. I request Dr. Deepak Vinod Francis sir to take over. Sir, to take over.
Check, am I audible?
Yes, sir. Audible, sir.
Yes, sir. Thank you.
Thank you, sir.
Good morning to one and all. Thanks for inviting me to talk during this occasion. When Sir was giving an introduction about me, I must say I'm not that great an expert, and I was wondering whether you guys were talking about me. I understand I dabble a little bit with most of what you said about, but I'm in no way an expert, and each and every day seems to be a learning curve for me as I go along. Definitely not up to the level as my previous speaker, but I'll try to do justice. Having said that, when I was listening to the previous talks, I must commend Dr. Saranya and Dr. Vijay for actually giving a summary of whatever the rest of the talk is going to be on. I think I can condense my lecture even further because most of what I wanted to talk has already been covered. Yeah? Okay. Is my screen visible?
Visible, sir.
Is it the presenter mode which is visible, or is it the
So the PPT is visible, sir.
PPT is visible? Okay. So what I'll be trying to cover about and what has been given as a session objectives for me is to talk about the evidence of decomposition, effect of climatic conditions on embalming. I will also be talking about embalming in some special condition scenarios like non-communicable diseases and communicable diseases, and a few basic ideas on improving safety, efficiency, and effectiveness. So, general question which we tend to ask is, why do we generally embalm cadavers? I can just foresee two regions where we involve in embalming cadavers. One is with respect to medical education, which is the bread and butter of us anatomists. And of course, the other aspect relates to post-death care. I'm predominantly a medical educationist, so most of my talk will focus more on the medical education aspect of it rather than on the post-death care, but I'll try to do justice for the later also. There are slight differences in the reasons why we do embalming in medical education as compared to post-death care. When you're talking about medical education, we are mainly talking about a short-term to long-term kind of a preservation of the cadaver, where we want to maintain the structural integrity of the tissue and also to help with safety and hygiene. And therefore, we are looking at it from the main goal of creating a good resource for use in anatomy and in medical education. On the other hand, when we are talking about And the whole idea of using it in medical education is that we need to prepare a good and safe model for medical education. Which we are in a time period where with the curricular changes coming in and the first year is getting reduced, we'll see that the need for cadavers and the approach we have to cadavers is changing, and it will have an impact on how we embalm cadavers in the future. But what we do know is that we need to embalm cadavers since and utilize it on the as a resource for the students, because it accomplishes few things which other modes of education in the medical field doesn't do. That is one. Nothing teaches 3D structural anatomy and relations like a cadaver does. We often underestimate it, but the amount of hand skills one learns during the first year is often attributed to cadaveric dissections. And it's also been shown that cadaver dissections help with developing empathy, concern, and other AIDCOM related skills. There's quite a lot of evidence, literature-based evidence which show that. On the other hand, when it comes to post-death care, what are the goals which we are aiming for? We are here in this scenario, we are trying to enable a form of closure for the relatives and the wider family and relatives of the patients. We are more concerned about short-term preservation to enable the body to be more presentable to the relatives when it's oftentimes it might be related to transport to a distant place. We work in a institution where we have patients coming from many places in the country. And oftentimes that would require transport if in case they pass away during the treatment duration here. And that requires us to embalm so that the body can be transported, and it helps to give a form of closure for the relatives of the patient. Who are the groups which will benefit from embalming? Of course, the MBBS students, and of late there is a larger group with the advent of cadaveric dissection-based teaching modules which are coming up. We do see a lot more PG surgical residents and faculty who are benefiting from the embalmed cadavers. We are now with the advent of plastination, etc. We do see AHS and the benefits of embalmed tissue being extended to allied health students and nursing students. And if you're looking at it from the point of view of post-death care, the family and relatives are the group who benefit from it. What do we generally embalm it for? Oftentimes it's related to dissections, prosections, and plastinates we use for teaching. Once in a while, we do use it for histopathology, where we retrieve specimens from cadavers for teaching histology. Museum specimens, surgical skill training, and in the case of post-death scenario, post-death cultural needs. What am I trying to say with the past few slides is basically that there is no perfect embalming solution. What we all need to work on and understand is that embalming procedures might need to be adapted based on this wide area of use, knowing the people who its benefits and the purpose for which it is used. It might vary between institution to institution. It might vary between state to state, etc. And that's something which we need to keep at the back of our mind. I was trying to look at what are the contraindications for embalming. I must add this slide can come across a little controversial in the sense that I tend to view things from the place where I was brought up, that is in a private institution. I did my UG, PG, and I'm in a staff in the same private institution. But the viewpoint might be slightly different in a government institution, mainly relating to what kind of cadavers we tend to receive. In a private institution like this, we rely solely on donations, voluntary donations. done to the right channel. So of course, for us, the absolute contraindication is the absence of consent from the donor and the donor family. And while in a government thing, the ambit might be slight, and government setting, the ambit might be slightly increased, and would also include the government can play a role, especially in the absence of donors or donor family. I'm mainly talking about unclaimed cadavers. Relative contraindications, of course, unclaimed cadavers, if you look at the document, it will often say there is always with the presence of permissions of a particular officer, kind of a mention will always be there. So even there, in these cases, there are always conditions which apply. So none of these end up being a absolute contraindication per se. One of the things which you come across during the time period of COVID was the importance we now given to infectious disease protocols when it comes to forming and contraindication for embalming. It might play a absolute contraindication during a particular time period, but it might be absent later. We all know that cadavers were not allowed to be embalmed during the COVID period. Now, there are a lot of embalming fluids which are currently being used. The most common things which we use are the formalin-based embalming fluids. In addition to that, with the advent of surgical skills training, we have fresh frozen, which ideally speaking is not an embalmed cadaver per se, because we don't embalm it, but rather we freeze it. And we have that intermediate in between few things which I worked around with. But it's part of the talk that's mainly related to embalming and its role in and its relationship to decomposition. We all know that we do embalming to prevent decomposition. What are the signs of decomposition we are looking at? We are looking at from a practical point of view. What do I need to look? Is decomposition of the cadaver and in contraindication for embalming? I would say no. I've seen cadavers which come in different stages of decomposition. The later stages, it becomes a little difficult. But in the early stages, it is possible to use the cadaver to its fullest. We have to keep in mind that when a donor accepts for donation, it places upon us a duty to utilize the body to its fullest. We have to maximize the use from it, because they're signing over thinking that it will be used to benefit the larger society. So it's nice to know the signs of decomposition which might be there when we receive a cadaver. And this comes in handy mainly because we live in a society where the importance of relatives is so much. Oftentimes, before we receive the body post death, it often goes for a public display where the relatives gather together and get closure, which is very, very important, and it helps to the relatives to grieve, etc. But on the other side of it is that I live in a place called Velo, where temperatures goes up to 44, 45 degrees during summer. And we do start seeing, what might be okay in a colder climate becomes unsuitable in a hotter climate per se. We often see cadavers post-death 24 hours coming in with late stages of decomposition, mainly because of the temperature circumstances which are present in our place. So when we are looking at it, what are the things we are looking of? Because we base our embalming fluid based on the signs which we see. We do see color changes, and one of the things we look for is discoloration, greenish discoloration in the lower abdomen, because we know that the abdomen where the gut is has a lot of bacteria, and it's one of the places where putrefaction can happen at a much faster rate. Odor mainly related to putrefact gases which are being released. We look for skin slips mainly because the subepidermal connective tissue tends to break down and your skin starts to peel. Crepitations and swelling of tissues can happen because of the gases which are trapped inside the body. And of course, at a much later stage, we come across a phenomena called purge, where the putrefactive end products, it might be gases, solids, etc., which escape from the orifices. Now, there are huge amount of literature classifying decomposition into multiple categories. They divide it into fresh, blood, destruction, dry skeleton, etc. But one thing which I've often found useful for me when it comes to looking at a cadaver and identifying whether it can be safe to embalm it and to decide on the choice of embalming fluid is to look for rigor mortis. So post-death, immediately soon after that, there's a little bit of primary flaccidity which happens, but within 6 to 24 hours, 6 or 12 to 24 hours, you see the muscle stiffening starting from the small muscles, it goes on to the whole body. And that mainly relates to the, if you remember, muscle contraction is dependent on ATP action. And when that stops, the body stiffens. And that's where rigor mortis comes in. But what happens is slowly over time, you will see that the muscles start to decompose and degenerate, where this system fails and the body develops a secondary flaccidity. So for me, this rigor mortis plays an important role in identifying, in the sense that if I receive a cadavers come 24 hours later, if I see a cadaver coming in and I see that the cadaver has rigor mortis, it's okay for me because I know it's in the early stage. But the moment I see a cadaver coming in post 24 hours, which is the usual time where we get it, and the cadaver is flaccid, the general tendency for me to think is that the putrefactive process has started to such an extent that it started affecting the muscles. And it would trigger an alarm in my head to think about something, think of a stronger embalming fluid. Bloat, destruction, dry skeletons generally tend to be a little later in the stages of decomposition. We can still do embalm, but there are higher chances that the embalming might not work. Decomposition depends on ambient temperature and humidity. And we see that often in our place where temperatures go high, we get a summer rain. And the humidity also picks up and the body degenerates very fast. There is an order of decomposition which is mentioned. The first thing to decompose in the body is the carbohydrates, followed by soft proteins, fats, hard proteins, bones. Now, but the interesting thing to note is vascular system is one of the last organ systems to decompose. So it's possible to arterially infuse embalming fluids to a later stage of decomposition. I've seen cadavers which have been decomposed with fluid using arterial perfusion, and that's worked out well. So whenever possible, if the vascular system is intact, try injective if you want to preserve. Few general concepts regarding the general types of cadaver, the usage of, based on the usage of cadavers. We do formalin embalming and formalin-based embalming and soft embalming here. But because fresh frozen is also now starting to become important, I have included in this slide. Please remember, the fresh frozen is similar to a person sitting in an OPD ward. We do consider them, the cadaver is considered to be highly infectious. On the other hand, literature shows that formalin embalming drastically reduces the risk of infection spread. I'm not I actually value formalin embalming quite a lot because after working with soft embalmed fluids, I've come to realize that the benefit that the formalin embalmed cadavers gives to undergraduate learning. I've seen teals, I've seen saturated salt solutions, I've seen Genelin. You have to understand most of our textbooks are written based on dissection on formalin based fixation, and that changes a little bit when it comes to using soft embalmed cadavers for undergraduate use. Formalin embalm you can use long term, up to 2 to 5 years, and depending on your fluids, you can even keep longer. But we never kept things longer than that. We've and most of the time, formalin embalmed solutions work mainly because they rely on formalin, which is a cross-linking fixative. When you come into the soft embalming field, you'll see that most of it has to deals with coagulant fixatives. When it comes to fresh frozen, very, very good for surgical skills, but unfortunately, usage is limited by the number of freeze-thaw cycles you can use on it based on the climatic conditions there. Soft embalm has benefits, has pros and cons, which can fit in both. So you might need to choose which one is the right one based on the circumstances or in which you're going to use it. So general concepts, decomposition is not an absolute contraindication if it's in the early stages. If a cadaver comes in a very late stage of decomposition, it's easy to bury the cadaver and at least retrieve the skeleton and use it. Rigor mortis, from my point of view, is a very good indicator of the state of decomposition. Oftentimes, I make my choice of what fluid to use based on the presence or absence of decomposition. Please remember there is no flowchart for the order of decomposition. There is a chance things don't go the way we expect. But having said that, when in doubt, even at the back of your mind, please use formalin-based fluids, inject locally and in the cavities. Don't take a chance. I would always advise a trial tank for observation just in case the embalming doesn't work. We've had experience of cadaver looks perfectly fine. It fulfills all the criteria for embalming using soft embalmed cadavers. We embalm it. We still use formalin as the immersion fluid. And we've seen that the infusion method or the arterial perfusion doesn't work. So it's always nice, especially when you're going into soft embalming fluids, it's always nice to have a trial tank for observation before you put it in a place where it will spoil the whole immersion fluid. Embalming and its relationship to non-communicable disease, very important topic for us, mainly because of the age group of our donors who we generally get. Most of our donors tend to be 50 and above in age. Most of them tend to be 60 plus. And we expect most of these donors to have one or more of these non-communicable diseases. The most common of them being diabetes, hypertension, cardiovascular disease. Oftentimes we dissect for MBBS students and see signs of cancer and sometimes chronic kidney disease. Each one of them affect embalming in various ways. For example, diabetes causes vascular fragility, affects fluid distribution. There can be, because of the hyperglycemic state, decomposition can happen much faster, or because of the presence of atherosclerosis, it can form a hindrance to particular limbs. We've had times when there's been severe atherosclerosis and where one limb has not taken up the embalming fluid. Cardiovascular disease, again, mainly related to atherosclerosis. It might require multi-arterial access. Cancers distort anatomy, block flow, chemotherapy might cause severe fibrosis. There might be metastasis. What tends to happen is that the anatomy learning you can do from these specimens sometimes tend to be lesser than the regular cadavers which we get. Chronic kidney disease, uremia will speed up decomposition, and any presence of any edema tends to dilute the preservative fluid which we inject. So we might need to inject a higher concentration of formalin substances. What about its relationship or its use in communicable diseases? We have to remember, I think Dr. Sarania had mentioned about the presence of HIV in cadavers post-embalming per se, and it is true. Looking at literature, any of these, what are we mainly worried about? We're mainly worried about the viral load which it carries: HIV, hepatitis B, hepatitis C. Because of COVID, we come to a realization that influenza viruses can also spread. Nipah virus, especially now that we see some aspects of it coming into the country. If you are elsewhere, it might be things like Ebola, etc. One thing which needs to be taken as a general guideline is literature might vary regarding when it might be active or not. But one thing it does is formalin tends to deactivate and make it to drastically reduce the chance of infection. Hepatitis B tends to be a little bit more virulent compared to HIV. HIV generally tends to be weak, and HCV being somewhere in between that. We don't know how much of a role does viruses like Nipah, etc. What the influence of agents, the formalin-based agents are on it. Bacterial agents, a lot of studies using colony-forming units, but general idea is that it tends to drastically reduce the number of colony-forming units which are present, which means the chance of infection is there, but it is much, much lesser. There have been studies which say that you embalm it, keep it at a low temperature, the chances of number of colony-forming units which are obtained from that is much lesser compared to those which are injected and kept in immersion fluids. There are a lot of studies done on fungal spores. The presence is shown, but its significance is queried. There's not much explanation on it. There's not much literature on how prion disease tend to work with embalming per se. Just a few general concepts at the end of it I'd like to just propose. A cadaver bottom is similar to seeing an untested patient in a high-risk infectious OPD. All unembalmed cadavers are to be considered highly infectious unless you have evidence to the contrary, in which in most cases we will not get that evidence. Full PPV personal protective material as needed to focus both on fomite and airborne. If COVID has taught us anything, it's that airborne transmissions are also possible in the embalming area. This is something we figured out during the time of COVID. I think Dr. Sarania also had mentioned about it in a talk. Please avoid using hosepipe or high stream jets for cleaning. Surface damping of the cadaver is important and needs to be done. Please avoid using high pressure streams or hose pipes for cleaning the cadaver, mainly because of its aiding airborne transmission. I generally like to immerse in a preservative solution in a separate tank, at least for the weekend, before undertaking any procedure such as shaving, cleaning, enema, just so that the surface contact with the embalming fluid might deactivate any of the infections which may be there. A lot of times we get diabetic cadavers who die due to diabetes, having pressure sores, having gangrene, etc. You need to be a little careful in how we utilize those cadavers. We have to make sure they are sterilized and please do remember when you're talking bacteria, there are a lot of multi-drug resistance bacteria which are coming up, which are common in the populace. Last thing you want is a nick on yourself and the spread of infection. Or the other worst thing is you end up being a carrier of any of these MRSA, etc., or methicillin-resistant organisms, etc. Thank you. I think that brings me to the end of my talk. Hello?
Thank you so much, sir, for sharing your in-depth knowledge in managing the embalming of high-risk cases with us today. Thank you, sir.
Thank you.
Kindly accept the memento and certificate of appreciation for this session, sir, as a token of gratitude.
Thank you. Thanks.
Now I invite Dr. Kumaran M. Sir, Associate Professor, Officer in Charge, Department of Forensic Medicine and Toxicology, Chikma Karaikal, to introduce our next speaker for the session, Dr. Sunil Subramaniam, sir.
Good morning. It's a great privilege for me to introduce my friend, Dr. Sunil Subramaniam, who is currently the professor and head of forensic medicine and toxicology, PIMS Pondicherry. He has graduated from PG Chandigarh and he has conducted more than 3,000 medical autopsies and wide range of forensic evaluations. He has 10 plus years of academic excellence in UG and postgraduate teaching. He has authored several national and international publications. He is also a former deputy vice principal at PIMS Pondicherry. He is a committee member of IQAC, MEU, ADCOM, NABH, and curriculum committees. He currently advocates for curriculum reform and competency-based teaching. I welcome Dr. Sunil to give insight on the topic Beyond Standard Anatomical Embalming, Exploring Diverse Techniques. I welcome you, Sunil. Thank you.
Good afternoon. Thank you, Dr. Kumaran, for introducing me. Indeed, it's a pleasure to be part of this CME. I'll share my PPT. Is it visible? Am I audible?
Yes, sir.
Am I audible?
Audible, sir.
Okay. So the topic given to me is Beyond Standard Anatomical Embalming, Exploring Diverse Technologies. So indeed, I should first admit that I'm not a subject expert in embalming, but we have the experience of doing funeral embalming for the past 10 years after joining over here. Indeed, we have been doing this embalming in autopsy bodies as well as in bodies that are being transported outside our country also. So the main objective of my presentation today are regarding the funeral embalming, embalming of autopsy bodies, and challenges in transport of human remains to other countries. Some case studies. I'll be discussing the recommendation given by various country studies, as well as we'll see about embalming a body with trauma and embalming of infants, and a few insight into special embalming procedures followed in VIP bodies. We'll start with funeral embalming. Dr. Saranya has given a brief introduction about funeral embalming. It is a process of preserving a deceased body, primarily to delay the decomposition so that the relatives can view it at the time of delayed funeral. And the second important purpose of doing funeral embalming is for transporting this deceased remains to their state or to their native place. Now, when you go into this legal requirements of transport of body, we need to discuss the legal requirements that are prevalent within our country for interstate transport, and then we will look into the global transport requirements. First, for transporting our Indian citizens from one state to other state, we require the following documents. First one is the deceased identification proof. Second one is a death certificate, which is given in the MCCD format, which can be accepted everywhere. The third one is an NOC from local police station, even though if the disease has died due to any natural causes. And the fourth one is embalming certificate. And the fifth one, we require a packing certificate or a coffin certificate if they plan to take the deceased remains through air transport. Now, these are the requirements if the person has died due to a natural cause. Suppose if the person has died due to an unnatural cause, then there will be autopsy happening. We need to give a certificate stating the autopsy has been done at this place, and a provisional autopsy report can also be shared. Those are the requirements for transporting the dead body from one state to other state. Now, coming to the legal requirements for global transport, in case any foreigner who dies in India and if his body has to be transported to other countries, we need a similar kind of requirements. First, we need a disease identification verification proof, then passport details of the deceased, death certificate, it has to be in MCCD format, embalming certificate, and then coffin packaging certificate. And then we need this consular certificate, which will be issued by the officer in charge of that country in the corresponding embassy office. And we need a caretaker undertaking. Actually, this procedure happens in two stages. First, we need to apply for this consular certificate with all the above certificates. Then they will come over here during packing of that body and they will certify it. And then only we can go on with the booking of the air tickets for taking this legal remains, deceased remains to their country of origin. So it is a two-stage process that will be happening for global transport. Next, we will go into this funeral embalming routine procedure. We have four parts in this: preparation, arterial embalming, cosmetic restoration and dressing, and the final one is coffin selection and casketing. Now, I'm not going to give a detailed view of all these procedures because we are not a subject expert, but definitely I'll be sharing what we are following in our institution. The first part is preparation. Definitely, we need to identify the disease with all the documents, including the death certificate, and make sure it is a death due to a natural cause. Then the sanitation process will happen where the body will be washed and disinfected, and all the natural orifices will be closed using sutures or eye caps if it is available. That's the preparation part. The second part is embalming fluid. What I have enlisted over here is the routine fluid which we are using for funeral embalming. We have calculated this for a 60 kg body weight. Average we used to take for 20 to 25 kg body weight. For every 20 to 25, we'll be using 3 liters. So if it is for a 60 kg body weight, we'll be using around 7.5 liters. It composed of formaldehyde, which is concentration will be around 37 to 41. And it comes with the added methanol of 10 to 15%. We'll be taking 3 liters of this. We'll be taking 1 liter of glycerol. We'll be using 500 ml of absolute alcohol, that is 95% surgical spirit. Then we'll be adding 3 liters of water, and according to the skin texture, we'll be adding iosin 3 to 5 ml. This is the routine composition of the fluid which we are using for funeral embalming. Next, coming to the funeral embalming machines, of course, the one you are seeing on your left is a vortex kind of thing, which is gravity-fed one. And what we are using in our institution is this one, which is a pressurized, which is on my right, which is a pressurized machine, which wherein you will have a gauge and you will have a knob to adjust the pressure according to the resistance. And the capacity will be around 12 liters of fluid can be fed at a time in this machine, which we are using. Though we are having this machine, our attenders and technicians prefer to use the old method which they were following. I'll show you the picture of this. This is a container which is around 7 to 8 liters. They used to fill this up, and they have a special procedure to keep this closer to the roof. So through gravity, it goes into the body, and they prefer this because of their easiness to use this machine rather than using the pressurized one. And they have been successful in doing this for the past 20 years. Next, coming to the funeral embalming, coffin and casketing, there is an international agreement for transfer of corpses, which we need to follow if we are going to do this. The transport has to be done only in a coffin that is impervious. It has to be either a double coffin, wherein the outer coffin will be made up of wood and inner coffin will be made up of zinc metal, or it can be a single coffin with a zinc lining. Now, I'll show the pictures of it. This is the inner coffin alone, which is made up of zinc metal. And this is where the inner coffin will be kept inside the wooden coffin. And they have specific specification like the thickness of the wooden coffin should not be less than 20 millimeter. That is 2 centimeters. Or you can use a single coffin with a zinc lining on the inner aspect. But again, they have specified that the thickness of the wooden coffin should not be less than 30 millimeter in this case. After keeping the body inside this, the entire coffin has to be sealed like this. And this has to be done in the presence of the representative from the embassy. And they will verify this process and they will seal it. Only after verifying and sealing, they will issue the consular certificate, which is mandatory for transport of the body through air cargo. Now, coming to the event of a death of a foreigner in India, it depends upon the manner. If he has died due to any natural death, we are going to just embalm and transport the body to the nation of their origin. But if it is an unnatural death, there comes the next objective of my discussion, that is autopsied body. The first autopsy has to be done in this body, then it has to be embalmed, and then it has to be transported. There comes the challenge, funeral embalming in autopsied body. Though we all know that literature gives various techniques like cavity embalming, hypodermic embalming, and 6-point embalming procedure. What we are doing here is little different. First, I'll explain about these things. So of course, Dr. Saranya has explained those things in detail. But the cavity embalming will be done in non-MLC cases where the body has not been opened up. Once you have opened up the body and the contents have been disturbed, you cannot do this cavity filling with concentrated embalming fluid. And there you need to do either 6-point embalming procedure and supplemented with a hypodermic embalming procedure. The 6-point embalming procedure is the following vessels has to be first secured, clamped, and then the infusion should start. That is both iliac artery, both the femoral artery, both subclavian or axillary artery, along with the carotid artery. Now, what we are doing in our institution is when we are doing the autopsy, we will make sure that we will remove as much organs as possible for various examination, like for histopathological examination and for viscera poisoning examination, we will be removing the organs. And whatever the organs that are left over will be surrounded by such gauze pieces which are soaked in the embalming fluid. So these organs will be rolled up with this gauze pieces and it will be stuffed inside. Empty rolls of this gauze pieces also will be soaked in and it will be kept and packed inside the thoracic and abdominal cavity. The entire body will be stitched actually in 2 layers. And then the hypodermic embalming, that is surface embalming, will be done to the limbs. And then the body will be packed in a water leak, non-water leak proof container is there. There is a Ziploc bag, which will be kept on the top of the body. And then it will be kept inside the coffin, and then it will be other procedures will follow. So that's the procedure what we are following for autopsy bodies. Now, let us see some of the case studies wherein the challenges of dead bodies received from other countries after autopsy has been made. The earliest study came in 1979 by Professor Michael Allen Green. He's a professor in University of Leeds. He brought the attention towards the various challenges he faces in the body he receives in UK who have died in other countries and returned to the homeland for disposal. This was the preliminary study that was made. Then later we started having a lot of studies from various countries. One is in 2014 from UK, wherein it is a 10-year study. They have reinvestigated 44 cases and they have found out the various difficulties and differences in the final diagnosis on the cause of death. Another single report study was published in 2015 from India. They actually have told what are the legal Indian perspectives they faced after transporting the body. Like they got repeated summons from the country to which the body has been sent regarding various investigation, ancillary procedures that has happened along with the forensic autopsy. In 2017, another systemic review article came out from Ireland where they have reviewed the legal procedures, document requires, the cost involved, the cause and manner of death in various bodies that has died in international as an international tourist. There was another study that came from Frankfurt, Germany, which is a 20-year retrospective study where they have analyzed almost 151 cases and they have advocated for a need for the second autopsy in all repatriated cases because of the various challenges and incomplete data they have received in this. In 2022, there is another study came from Hamburg, Germany, wherein they have analyzed 307 cases and they have done a re-autopsy in 238 cases. And they have also advocated that there are lack of standardization in autopsy procedures. So all these things are pointing towards the various lacunae and challenges, and they have given the solution and recommendation, which I'll be summarizing at the end of this. Another study in 2024 from Turkey, where they have analyzed for 12 cases. They have also told the various challenges and they advocated for an international standard for medical legal autopsy. So what are the issues that are being documented on bodily remains that has been repatriated from foreign countries there are primarily 4 categories. The first one is autopsy is not conducted in all unnatural death or suspicious death in some countries. And provisional autopsy report or other forensic investigation are not available with the bodily remains. And next one is in natural death cases, the cause of death certificate which was issued is not in WHO format. And finally, documentation of organs retrieved during autopsy has not been given along with the bodily remains. Actually, we retrieve the organs for various further investigation, like for detection of any poison or alcohol. Sometimes we may retrieve it for histopathological analysis. We need to document all those things and send it along with the bodily remains. Otherwise, there might be a suspicion of illegal organ trade. So in all medical legal autopsy cases, they have given certain solutions and recommendations, which we will see now. The first one is there should be availability of documents of medical treatment along with the mortal remains if the person has been treated in a hospital or institution. And we have to make sure there should be a cause of death certificate in the WHO format that has to be sent along with the bodily remains. These are for natural deaths. If it is for unnatural death and we are doing an autopsy, a provisional autopsy report has to be sent along with the mortal remains. And the documentation of list of organs that are retained for various ancillary investigation has to be furnished along with the autopsy report. They also recommend that there has to be some kind of opportunity for the investigating officer in those countries to have access to the final autopsy report and other ancillary investigation reports. Either you can give along with your provisional autopsy report, you can give your contact details through which they can communicate for the final autopsy report and the reports of other ancillary investigations. And they also recommend that a separate set of viscera could be preserved during autopsy, and it can be handed over separately to the authorities during repatriation, so that they can also do whatever ancillary investigations they want in their own labs, and they can cross-check with our reports. So these are the recommendation and solution they are giving for the medical legal autopsied bodies which are being transported to other countries. Now, coming to the next part, which is funeral embalming in a body with trauma. In India, if whenever we get this body, it is going to go for autopsy. But for other sakes, we are going to discuss the challenges over it. We have challenges like the vasculature is going to be completely severed in these cases. There is going to be internal bleeding and discoloration. Surface injuries will be there, and reconstruction is a challenge. Now, often this arteries, when they are severed, you cannot embalm the fluid because it is going to be leaking out, and we need suturing and clamping of all these major arteries to control the leakage, and so that we can ensure proper fluid embalming and distribution. And the second one is internal bleeding. This can cause discoloration. So before starting of embalming, this internal bleeding source has to be arrested, and all those fluid has to be, all those internal bleeding has to be removed as much as possible. Coming to the surface injuries, open wounds and laceration has to be addressed. They have surface embalming has to be injected. The fluid has to be injected in all these wounds, and it has to be properly sutured in order to prevent infection and in order to improve the body's reappearance. Reconstruction is always a challenge. Depending on the extent of the trauma, reconstruction and reattachment of the limbs might be necessary. So here, mostly the techniques we follow is sectional embalming. Those areas we will try to anastomose the arteries as much as possible, and hypodermic needles will be used for injecting the fluid into this body. And reconstruction we can do, but not to that extent. For cosmetic purposes, we will do as much as possible, which we can do. Next is funeral embalming in infants. The challenge over here is the small size and delicate nature of the vascular system. So usually the preferred method of embalming in infants is cavity embalming using infant trocar, and then surface or topical application of the embalming fluid. Another method, what they usually advocate, is immersing the fetus in 10% formalin after this cavity and topical application. Recently, this research paper has been published from AIMS Rishikesh, where they have found a cost-effective approach for fetal embalming. They have advocated one constituent solution. The contents have been given here. And you can see the concentration of various constituents of this fluid. What they are advocating is they are advocating for an arterial embalming through femoral vessels in infants, and as well as to inject this fluid through anterior fontanelle to embalm the organs of the brain and other structures around. So simultaneously, they are advocating for this two. One is arterial embalming through femoral vessels. Another one is cranial cavity embalming through anterior fontanelle. And they are also saying that the body of the fetus has to be covered and wrapped inside a cotton roll, which are being soaked with this embalming fluid, and left it like that for at least 2 weeks. And they have found success. They found this method to be more successful in preserving the fetus than the traditional methods. And they have even published an image of a fetus that has been embalmed by this methodology. And this is a fetus, the photograph has been taken after 2 years of embalming, and they find it quite useful. They also advocate this as a best method for bigger fetuses, which are of higher kgs. Then this can be a better method for embalming the fetus. The final part is on special embalming or VIP procedures. There is a procedure called extreme embalming. It is a specialized post-mortem process that goes beyond traditional embalming to create a life representation of the deceased. This has been followed in Western countries, particularly in Latin America, where VIPs have been embalmed during these procedures, especially for the cosmetic appearances. This is the photograph of an embalmed body of King Martin Luther, and they have advocated this for various other purposes, other VIPs also. Like what are the main properties of this is they do an intensive cleaning, sanitation, and restoration techniques than standard embalming. And they try to, the goal of this is to make the disease look as natural and lifelike as possible. This includes facial reconstruction, cosmetic application, and even hairstyling. And the final thing is they will make the body to be posed in a particular pose so that it suits their personality, hobbies, or profession. Sometimes even recreating the scenes from their life. So that is about special embalming which they are doing in VIP bodies. And these are my references. And I would want to say or end this talk by saying that art of life lies in constant readjustment to the surroundings. So challenges when they come, we have to readjust with the surroundings to go ahead. Any questions? I'll be happy to take it. And thank you for the opportunity. Are there any questions in the chat box which I need to answer? Regarding funeral embalming, in our institution, Department of Forensic Medicine is doing it, but there are other institutions where anatomy is also conducting this. As per the Tamil Nadu Anatomical Act, I remember that uh, for voluntary body donation alone, the department which is utilizing the body cannot be involved in this, whereas the other department can procure it and then give it to the Department of Anatomy for using it. But there is no restriction or any legal guidelines which department has to take up the responsibility of funeral embalming. Thank you. Yeah, the person who is conducting the funeral embalming are competent enough to give authority. We have been doing this for past 20 years and we have issued from our department the embalming certificate which are being accepted internationally. Again, there is no restriction like which department has to do it. Whichever department is doing the funeral embalming can issue the embalming certificate. Regarding interstate transport, I have given you the list of documents that are required. The death certificate is a must. Embalming certificate, deceased identification proof is a must, and NOC from the local police stations. If it is going to be any other transport, like to get embalming certificate. Embalming certificate format, I can share it with this group. They can share it with you all. The certificate, embalming certificate format is very simple. You need to mention the identification details and cause of death. Along with that, you have to mention that what is the time and date of embalming. And you need to add a statement that the body is free for any infectious diseases. after embalming. There is no validity of the certificate. There is no appellant authority which will be checking the validity of the certificates. Like if you issue the certificate, it is for the transport of the body from one place to another place. No, we will be doing the embalming only after making sure that the body doesn't has any injuries, as well as there should be a clear-cut cause of death certificate from a medical officer. So if there are no death certificate available wherein the cause of death has not been mentioned, or sometimes this also happens, they will bring a broaded body and they will say they want to embalm it. For all broaded cases, we are making it as an MLC and a proper police investigation will follow. Thank you. No, without the cause of death certificate, you cannot do the embalming. That is the basic requirement for doing an embalming. Even if the body has been donated to your department for academic purposes, you have to make sure that there is a cause of death to make sure that the person has died due to a natural cause. Thank you. I think there are no more questions. What is the fluid composition of extreme embalming? Even we don't have any idea about it. Just I want to introduce you that there are some procedures like this. What are the procedures of unclaimed body? If, as per the Anatomy Act, Tamil Nadu Anatomic Act, the investigating officer can donate the unclaimed bodies to the medical institution. We are being accepting those things. Like he will first advertise in local language newspaper and English newspaper about such a body, and the detaining time over here is 15 days, 2 weeks. So in 2 weeks, if nobody comes and claims the body, the investigating officer, that is the police officer, will issue a letter stating that since there were no person to claim this body, we are donating this body to your institution. So after getting a NOC, I mean the letter from the investigating officer that this body can be taken up for medical education, then only we will do the embalming. Yeah. Yes, that's how we are procuring the unclaimed body and we are donating it to the Department of Anatomy. The usual time limit which we give for funeral embalming is 2 weeks from the date of embalming until the body has been stored properly in a 4 degrees centigrade, or if you are taking out, there are portable embalming and portable freezers which in which you can keep the body. Now, in the certificate, we will not be mentioning any validity. This is orally we are giving over it. Now, death certificate has to be signed only by an MBBS graduate. who has been provisionally admitted in any medical council. Others cannot issue a death certificate. We are issuing the embalming certificate in English only, even for the bodies that are being transported to France, which we normally do from here. That's the language we are following. Can we end the session? Are there any questions? Yeah, if a old person dies at home due to natural cause, then the medical officer who has seen the case in the last 7 days can certify it after making sure that there are no foul play in the form of any external injuries on the body. Otherwise, if a person dies in a home due to any natural cause, it will be considered as a non-institutional death for which the cause of death has not been certified. Then it will become an MLC. The police investigation will go through. These challenges usually arises. There will be an elderly person around 90, 95 years and they die at home. They would have not been visiting any medical officer in past 1 or 2 weeks. So in all such cases, the police intimation has to be given. Then the police will inquire and they may give an NOC that in this case, there is no need for any post-mortem. That's how it will go. With that NOC, they can approach the municipal office and get the death certificate. Sorry, I didn't understand this question. Even if OIT is a registered body in case of natural death at home for old age, can you provide little clarity on that question? If a person dies due to old age, due to any natural cause at home, then that body has to be certified by a doctor who has seen him in the past 7 days. And he has to come to the site, examine the body, make sure there is no external injuries or any other foul play. Then he can give this death certificate based on his experience in the last 1 week. But if there are no available doctors like that, they have to take it to the nearest hospital where they will register it as an MLC case because it is a broad death case. And a police intimation will be given from the hospital. Police will inquire and they can give a clearance or no objection certificate stating that it is a natural death. If they find any foul play, they will subject the body for post-mortem examination. Yes, even if it is a natural death, if the doctor is not able to give the cause of death certificate, it has to be registered as an MLC case. Thank you. In case of MLC case, funeral embalming can be done by any department. Even anatomy can take up that. In our institution, we are doing the funeral embalming. So in both MLC and non-MLC cases, we are doing it. If it is an MLC case, first autopsy has to be done, and then only you can do the embalming. That's the only requirement.
Thank you, sir. Dear delegates, rest of the questions will be noted and it will be addressed at the end of the session. Thank you so much, sir, for enlightening us with your vast knowledge about various techniques of embalming the cadaver.
Thank you.
Kindly accept the memento and the certificate of appreciation for the session as a token of love.
Thank you. Thank you so much.
Dear delegates, now we will move forward to the panel discussion session on optimizing body donation for medical education and research, challenges and solutions. Now I request our Dean sir to occupy the dais. I request Dr. Vidya G, ma'am, Assistant Professor Anatomy, JIPMA Puducherry, to introduce the panelists. The panel will be moderated by Dr. Vidya ma'am.
Okay. That goes me.
Chat close me.
Okay, okay.
Hello, Dr. Ambiga, can you hear me?
Yes, ma'am, audible. It's audible, ma'am.
Yes. Shall I take on the session?
Yes, ma'am, please.
Yes. Just before getting into the discussion proper, I would like to confirm like all the panelists have joined. Dr. Kumaran sir, can you hear me? Kumaran sir?
We are here, madam.
Dean sir is there with you.
Yes.
Sir, can you hear me, sir? Yes.
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 Audible.
It's not audible, sir.
It's audible and clear, madam.
Okay, thank you. Navita ma'am, Dr. Navita ma'am is there? Have you joined, ma'am?
Yes, ma'am, I'm there. And
Yes, yes. Thank you, ma'am. Thank you. Dr. Rajshekhar, sir?
Yes, I'm there.
Yes, sir. Dr. Rai, sir? Ray, sir? From AIMS? Hello, sir. Can you hear me, sir? Dr. S.B. Ray, sir? I think some issue with sir.
Madam?
Can you check? Ray, sir has joined.
SPD sir is
SB
joining.
Ray.
Sir will join shortly. 1 minute.
Sir will join shortly. Should I wait for that?
Madam, you may please proceed. Madam, I would like to
Okay.
bring your kind notice that today now we have Dr. Kannagi Madam, Medical Superintendent of Government General Hospital, Karaikal. Madam
Okay.
is also joining with us for the panel discussion.
Okay. SSP ma'am is there?
Madam will join in some time. She has got an important case now.
Okay.
Thank you.
So shall we start the discussion now?
Yeah, sure. We can start, ma'am.
Yes. Is the screen visible for all? Kindly let me know, is the screen visible?
yes,
Over
yes, yes.
Randa.
Yes,
No,
madam.
no, in the idillam irukkum. Okay. Yes. First of all, I thank for giving me this opportunity. It's my immense pleasure to conduct this panel discussion. I wish a very pleasant morning to one and all joined here for our discussion. First, I would like to welcome and introduce our beloved panel members. So, let me introduce first the first panelist, Madam Lakshmi Saujanya ma'am, IPS, Senior Superintendent of Police, Karaikal District, Puducherry. Madam will be joining us shortly. The next speaker will be Dr. Kusha Kumar Saha sir, Professor of Forensic Medicine, Dean of Jibmer, Karaikal. So welcome you, sir. It's my immense pleasure and I'm very glad to interact with you today, sir. Next, our beloved Professor, Dr. S.B. Ray, sir, from AIMS, New Delhi. Welcome, sir. Dr. Rajashekhar, sir, Additional Professor of Anatomy, Jibmer, Puducherry. We welcome you, sir. Dr. Navita Agarwal, ma'am, Additional Professor of Anatomy from AIMS, Bathinda. Welcome you, ma'am. Dr. Kumaran, Associate Professor and Officer in charge of Forensic Medicine Department, Jibmer, Karaikal. And finally, Dr. Hemal, ma'am, Quality Assurance Officer, Mohan Foundation, Chennai. As Dr. Saranya ma'am informed, we would like to welcome our medical superintendent also for this discussion, and we are very happy to have ma'am on this discussion on board today. So before getting into the topic proper or a discussion proper, I would like to introduce what we are going to do today in this discussion and the flow in which we are going to carry out this discussion, which will be really helpful to clarify, to have a better clarification of the viewers. As we all know, the major source of cadavers will be unclaimed bodies. But nowadays, the number of unclaimed bodies what we are getting is reduced due to various reasons. So we would like to start a discussion on how to make available of these unclaimed bodies as a major source of cadavers once again. Then we are really interested in the challenges we are facing we are dealing with the unregistered bodies, donated bodies, as there are many logistics to be sorted out. Finally, we will take out this platform to explain the proper procedure of once to register the body for donation to the nearest medical college. Since there are many lacunae in that, we try to fill up it with our discussion today. In addition, we thought it's high time to explore various ways to promote more body donations and unravel the myths related to the body donation. In this contest, we have framed a set of questions to each one of the panelists, and they can freely express their views with a time limit of 2 minutes each. Then the question will be open for the forum, and if any one of the other panel members wish to add upon, they are pleased to do so with the same time limit. With this, we will start our panel discussion on how to optimize body donation for medical education and research, the challenges, and particularly the solutions, what we are going to do for that. Shall we start the discussion, dear panel members?
Yes, please.
Yes. So let us start the discussion on unclaimed bodies first, because there are many myths and many things to be sorted out on this. So the main question for we anatomists and also the forensic medicine people and the police people also, everything, the main query what we have is like, can we use this unclaimed bodies for academic purposes? So the decision making is very tough for us. So we thought like we can have some insights related to this decision making. So first, I would like to hear from Dr. Kusha sir. What are the laws regarding the unclaimed bodies which are in function now? Like how we can make that law comfortable for us to make use of this unclaimed bodies for the academic purposes. So please, sir, could you please explain us what are the laws regarding the unclaimed bodies and whether autopsy should be done in all the unclaimed bodies, whether it is mandatory or not?
So, thank
Sir?
you. It is audible to everyone?
Yes.
Yes, sir.
Huh.
உங்களோட pictures
So,
நல்லா இருக்கு.
thanks to the organizer to giving me the opportunity as a panelist for this topic. And your question is that can unclaimed bodies be utilized for academic purposes or not? In my view, yes, it can be accepted the unclaimed body for academic purposes, but with certain legal and ethical considerations.
Yes, sir.
So there are certain legal provisions are there, like Anatomical Act is there, okay, to utilize the unclaimed body for the academic purposes, where you wait for 72 hours to consider the body, and the authorities authorize the transfer of unclaimed bodies from hospital, police, or legal authority to government medical colleges. So you have to follow the legal provisions. One is the Anatomical Act, another is the hospitals accept the bodies for our academic purposes, educational value, which is very, very important for the students to learn from the bodies, dead bodies, and implement at the end of their career and throughout the career, and the teaching of the human anatomy, which is the basic course for all the MBBS regulations. So while we are using the unclaimed body for the academic purposes, we should give the respect to the dead bodies, and the students should give the awareness about the ethical the dead bodies, and without the unclaimed body academic purpose, the medical education is incomplete and it is less effective, because most of the things we are from the live, before going to the live patients, we are going through the dead bodies procedures. And ethical legacy also, I told that it is very, very important for the accept. So there are certain conditions where we cannot accept the unclaimed body without the police or legal clearance, okay?
Yes, sir.
And if the legal holding period is not passed before 72 hours, we cannot take the body for academic purposes. If there is any suspicious or circumstances as there, or any problem is there, or there is need of collection of the evidence, in that case, we cannot touch the dead bodies. And another important thing is that which is lacking, that the cadaver registers. It is very, very important, like the dead body organ. Sorry, in the case of the organ donation, we have the registry. We must have these dead body registries. to maintain the chain of custody, which is very important so that we can get easily most of the places the dead bodies.
Okay.
And coming to the summary, that the unclaimed body is used mostly for the medical teaching, research, and surgical training. And we have to follow the State Anatomical Act, and getting the body, we must need the clearance from the police as well as the magistrates if required, and maintain the dignity of the dead bodies. And we must use the dead bodies for academic purpose in a transparent way. And it is the responsibility of the institutions as well as the legal authorities for the responsibilities to provide the body and utilize the bodies in proper way. Thank you.
Thank you so much, sir. Thank you for the insights you have given. So all the points what you have told about the unclaimed bodies have been well taken. So I would like to ask Dr. Kumaran, sir, do you have anything to add on this, sir? Whether autopsy should be done in all the unclaimed bodies? Can you just enlighten us with your experience?
Autopsy is not required in all unclaimed bodies. When the physician, during the process of
Sir, your voice is feeble, sir. Can you please?
Am I audible, madam?
Yes. Yes, I can hear you, sir. Yes, I can.
So autopsy, so once the unknown bodies as designated as medical legal case. So when the doctor suspects something in the if he suspects it is a medical legal case, he has a suspicion. Those bodies are indefinitely should be autopsied. But here the Anatomy Act comes into play. So when an unclaimed bodies is there in the hospital, so the Anatomy Act comes into a rescue where the in charge of the hospital shall inform to the appropriate authority of the authority appointed by the government of the state. This authority may take a decision on to give to the body to the designated or approved medical colleges. This appropriate authority is a government official appointed by the government of the state. So he takes a decision whether it has to be given to the medical colleges or not. So that's how the Anatomical Act comes into rescue in such situations.
Yes, sir. So that will be my next question. So that will be my next question. Like, who can decide to waive off the autopsy and transfer the body to the medical college? Because in Anatomy Act also it has not been clearly mentioned who will enforce the law and which is the authority, whether the anatomist or forensic department or the investigating officer who will take a call in waiving of the autopsy. Sir.
So,
usually what is happening in our institute or in general what's happening.
So once the case is registered as medical legal, the investigating officer has the highest power to decide on what to do with that case. So
okay.
if convinced that no foul play is suspected and this body can be no fault is suspected and nothing is there, it can be transferred. He can give a proper insight on that and he can decide whether to, and with the help of his superiors also, he can decide and he can give the permission to be taken to anatomy for the donation.
If it is not a medical legal case, sir, how can we go about?
If it is not a medical legal case, the Anatomical Act comes into the play. Unclaimed bodies, the appropriate the in charge of the hospital informs to the authority appointed by the state government, and this authority will decide on this. So the Anatomy Act is very clearly mentioned. If it is a non-MLC case, the in charge of the hospital may inform the authority appointed by the government, and he takes a decision. It is very clear in the Anatomy Act. Anatomy Act has been formulated in most of the states, and a few other states also follows this. And all the Anatomy Acts in different states have the same content, even though the state name may change, but 90% of the content is the same.
So one more small query, sir. Like in the previous session, Sudha session, ma'am noted like told like if a person is belonging to a particular jurisdiction is being traveled to some other place, and that place there something had happened to him and he was dead. And in this situation, who will take a call, sir? Like this body should be, because many are having all these queries in their mind. So I think this is a good platform to explain all the things clearly over here.
Can you repeat the question one more time, madam?
Yes, if a person of one particular jurisdiction.
Okay, he's from
Yes,
a different district, maybe from different district. If you
yeah, one particular district, maybe one particular district is going to some other place, and there something had happened to that person and he was dead. and he was a registered body donor also. Is there anything to go by law in that situation, sir? Like to which place the body had to be handed over?
Madam, it is again,
Since
the Act states that once the body, he dies, he becomes unclaimed in this particular hospital. As per your question, he becomes an unclaimed in the particular hospital. And till 72 to 48 hours, the police will search. The police has a role to play there. Once we have to intimate that this is the day. So once a search operation is there to find out their relatives, 99% they will find the relatives. Again, if he doesn't, if the relatives are not traced back, he becomes the unclaimed body again.
yes, sir. Yes, sir. Because my next question will be like that. Like, we'll move on to the next question, sir. Thank you for that information. What this is what I should wish to ask you in person. Like, what protocol should be followed within the police station, and what protocol should be followed within the hospital? Like in Jibmar, what we are doing? What is the protocol, sir? We are following for unclaimed bodies. I think Madam can explain well about the protocol followed in the police station. Once Madam join, we can get the answer from Ma'am. In our institute, what will be the protocol which to be followed in the hospital in case of unclaimed death, sir?
The question is for Raj Segi, sir? Or
It's for you only, sir. What protocol is followed within the hospital when you receive an unclaimed body?
so once we receive an unclaimed body, we have to while receiving the unclaimed body, we should have the no objection certificate from the police, the letter of handing over certificate from the anatomy department, and if there any FIR or death certificate is mandatory, FIR or other legal formalities that has to be completed by the police, and if at all a police inquest is there for lookout notice, those things also should be added, and we follow the provisions in the Anatomy Act.
Okay. This is what we are following in Jibmar, right, sir?
Yes.
Yes. Thank you so much.
And the identity. So once
Identity. Yes, yes, sir.
body, we have to preserve the identity of the deceased. We have to take, if at all Aadhaar is available, take a photograph. If required, we can take the fingerprint and we can preserve it for in case any claim. But one thing which I wanted to add that whether this
Yes, I have been unmuted.
This to be incorporated in
I have been unmuted.
this
Sir.
to be incorporated. Whether
Yes.
we can
Yes,
suppose
sir.
in few of your session we have one more thing that claim after donation. Claim after donation. In you one
Sir,
of you maybe.
excuse me, sir. Sorry, sir. Can you come again, sir? It's not clear.
Yeah, the identity of the deceased has to be preserved. So
Yes, sir.
we have to take a nice photograph. If possible, we can take fingerprints, preserve it in the record.
Okay, okay, okay. That is a good insight, sir. That is a good insight. So yeah, we can able to take the fingerprint also. We are allowed to take the fingerprint, and we have to preserve for identity in
We
future.
are accepting the body, so we
Yeah,
can
yeah.
and then preserve it. So in case any future is there, future allegations comes, these comes
Yes.
to rescue for the identification.
Okay, sir. Okay, sir. Thank you, sir. Thank you very much for the insights. Right. Now, I would like to get few information from Dr. Navita, ma'am. In this situation, ma'am, like if you receive an unclaimed body, what will be the protocol followed in your institute, ma'am? That is AIMS Bathinda. So when you receive an unclaimed body, how you are going to manage? And what is the protocol you are following there, ma'am? Please, could you please explain your experience, ma'am? Yes, ma'am.
Ma'am, at AIMS Bathinda, we have not yet received any unclaimed bodies because we are a new institute and Punjab state government has not coordinated with us for unclaimed bodies. Though there's a provision in Punjab Anatomy Act to have unclaimed bodies. For these, what I understand is most of the unclaimed bodies are being given to the other government colleges. But we have appointed our own officer at AIMS Bathinda, who is the medical superintendent. And in case there are unclaimed bodies, through this official of AIMS Bathinda, the bodies will be transferred to Department of Anatomy. And it has to go through the process of the police recognition. And as Dr. Kumaran has already said, the paperwork has to be done completely in this process.
Anything to be added, ma'am? Like you would like to add anything to this, ma'am?
Only thing that I would like to add is, as if I'm listening to the other speakers here, the unclaimed bodies process is being followed at your place. But as I have heard Dr. Sudha Session saying that in the morning, most of the unclaimed bodies these days are not available. The bodies that we are receiving in Punjab are mostly from the NGOs, that is, or the registered bodies that are being available in medical colleges at Punjab.
Well taken, ma'am. Well taken. Yeah, you are receiving bodies from NGO organization also. That's a good.
Yes, yes, sir.
Because I think in your place it is forming a major role. NGOs are forming a major role.
Yes, in Punjab, NGOs are very active for body donation.
Yeah, that is a good information, ma'am. Thank you so much. So what are next? We will move upon the challenges faced in accepting the unclaimed body. So in this regard, I would like to hear from Dr. Rajshekhar sir. What are the challenges faced during accepting an unclaimed bodies? So, sir, could you please share your experience on these things, sir?
Yeah, the thing is, unclaimed bodies can be present at two locations. One is outside the hospital, and one is inside the hospital. Say, for example, the patient comes to the hospital, gets treated, and somehow passes away. And in an unfortunate situation where there are no people accompanying him, so he becomes an unclaimed body.
Yes.
But he is a known case and with a known identity because he got himself admitted with his name and other details. So in that case, the body after death will be transported or shifted to the mortuary under the control of forensic medicine department, and the police will be intimated. Then the police has to process the papers, like finding out the contacts or the near relatives of the deceased, and the hospital administration will be advertising the details of the photographs and the other things in the newspapers. So this actually takes a lot of time. So by that time, practically speaking, a month or 2 months time will also pass sometimes. And finally, the police will decide that yes, there cannot be any relatives that can be traced. Therefore, since the cause of death is very clear and the death has happened within the institution, the body can be transferred to the medical college. So that this decision usually takes a lot of time, and by that time the body would have been very well dehydrated. The body will not decompose because it is in cold storage, but then it will be severely dehydrated, and such severe dehydration will actually affect the embalming also. So we have to modify our embalming protocol to cater to that dehydration.
Well taken, sir.
So that is actually unclaimed body within the hospital, and the no cause of death is known and the person is known, but it is unclaimed. The second situation is when there is any death happening on the road and nobody is claiming that body, and we don't know whether the body, whether the deceased has died of natural or unnatural cause. And in that case, police will take even further more time to decide whether to waive off the autopsy or not, and then to do once again all this paper procedure, newspaper advertisement, all these things will take up even further more.
Okay, sir. Sir, can you hear me? So, sir? So I think there is a small interruption in sir's connection. So from sir's explanation, the thing what we are understanding is like for accepting an unclaimed body or for using the unclaimed body, the main challenge will be like time limit, time duration. So processing time is getting more and more so that the body condition is not fit for embalming and it is becoming wasted. So we should do something, or there should be a particular or a legal actions to be taken so that the process can be completed in a quicker way and the unclaimed body can be used for a medical education. In this regard, I would like to ask Dr. Kusha sir to add a few things to this question, like what are the challenges faced during the acceptance of an unclaimed body, being a forensic expert? Sir, could you please explain us like what are the challenges faced by you during accepting an unclaimed body, sir?
Yes, the thing is that most of the points as well spoken by the Dr. Rajsekharan.
Yes,
But
sir.
I can divide the challenges into four aspects. One is the legal challenges,
Yes, sir.
where there is ambiguity
Yes, sir.
for the, because there is already the act is there that how the body can be hand over to the anatomy department or forensic medicine department.
Okay.
But different states has different act, so there is ambiguity in the legal procedures.
Yes, sir.
Another is the delay often occurs due to the lack of clarity about whether the police or magistrate or hospital have the final authority to hand over the body. Sometimes we are facing the problem.
Yes,
Sometimes
sir.
there will be talk between the police, hospitals, who will sign, who will give the body. There is a delay in that.
Yes, sir.
Another is that waiting period. Already Dr. Rajsekharan said that waiting period. Sometimes
Yes,
we are getting the
time
body,
deal.
the timing is delay. And there is no unified national policy where
Yes, sir.
we are lacking. And number one is the legal challenges. Second is the ethical challenges, how to give the respect to the dead bodies. Most of the time, the body is coming and they're kept in the outside the mortuary. No one is there to look after. So that the case, giving the proper respect to the dead bodies. Okay. And number
Yes, sir.
three is the students. Sometimes they're working, whether it's anatomy or the students who are joined in the forensic medicine to uh, give the dissections or whatever the body, they must have little fear. So sometimes with the challenges we are facing,
Yes, sir.
sometimes students by seeing the dead body, they become faint and they are not ready to accept to do the work in front of the dead bodies. These are the challenges. Another is the institutional or administrative challenges we are facing. Department, because sometimes the department will tell that I have so much burden, why I have to take such a burden to get the body and all these things. So that is why most of the places they will not take that interest to get the dead body. Okay. And
Yes, sir.
storage of the cadaver in the anatomy or forensic medicine, because storage, we don't have that capacity to store the dead body. These are the also challenges in the cold body storage. And procedure challenges, incomplete documentations.
Yes,
So
sir.
whenever you are getting any dead body, unclaimed bodies, we have to first see that it should be the
Document.
clear from the police side,
Yes,
and
sir.
the proper documentation has been maintained. What Dr. Kumaran already told, that identifications and all the details should be properly maintained. Without that, don't touch the body or don't take the bodies.
Yes, sir.
Okay. And transportation and storage.
Yes,
Okay,
sir.
where the body should come, how to transport. Okay,
Okay.
if
Yes, sir.
someone is ready to give the body, okay, so
Yes,
that
sir.
we have to take a decision how to transport that body. Sometimes the administrations, they will tell, no, I don't have a facility to provide the vehicle.
Yes,
So
sir.
we have to take that things in our mind, that how to get the body and code. And finally, the most important, the coordination between the all the stakeholders,
Yes, sir.
police, authority, departments.
Yes, sir.
So we must have worked together.
Yes,
Okay,
sir.
if there is lack of any one of the department, then it is very difficult to get the unclaimed body in our institute.
Yes, sir.
So these are the challenges. Finally, I am telling, one is the
Ethical.
legal challenges, ethical challenges, procedure challenges, and institutional challenges.
Yes.
So these are the four
Challenge.
categories I just explained to you.
Thank you so much, sir. Thank you so much for your clear explanations. So really, we got many insights into this. So all these challenges definitely has to be addressed. Then only we'll be able to get more of unclaimed bodies, and this can be used as a resources for the medical education. Dr. Rajshekhar, sir, can you hear me, sir? Is it okay now? Yes.
Yes, please.
I think there was an interruption in between, sir. Sorry for that.
Sure.
So now I would like to hear from you, like, what are the precautions must be taken in while accepting an unclaimed body, sir? Could you please enlighten us with few points so that it will be useful for the listeners?
So first precaution is the police clearance. This is the must what we have to take for accepting the unclaimed body, and we have to make sure that the police clearance certificate is given in proper format,
Police
and there
clearance
is a
certificate.
signature and seal of the
Yes, sir.
once that is there, and we have to make sure that the other documents are also there, such as the medical certificate of legal cause of death and certificate of medical cause of death, and if at all, are there any case sheets pertaining to the cause of death if the person has died in hospital, that would also be better. So these things are must. One is
Sir, your voice. Sorry, sir.
report, and the other one is the police clearance certificate. And since we don't know the cause of death, so we should once again consider all the bodies as HIV.
So I think like SAS, there is an issue in SAS internet connection. Sir, is it okay now? Can you hear me?
Yeah, I can hear you.
Sir, like what you are talking for the last 2 minutes was not clear, sir.
So the thing is, we have to take care of the
Clearance certificate is okay, sir. And next to that, what all the points you have told, sir?
we have to see if there is any availability of any case sheets so that we'll have some idea as to cause of death, and so that we can plan the embalming accordingly.
Yes, sir.
That is the second one. And the third one is we have to plan the embalming, and we have to assess the body. Sometimes, usually, it will be dehydrated body. And sometimes, if the cold temperature is not maintained properly, there will be decomposition also. And therefore, we have to tighter our embalming solutions accordingly.
Okay, sir. Okay. Thank you, sir. Well taken, sir. So we will be taking note of all these things like clearance certificate, case sheet has been there, and the times should be managed properly, and everything is well taken, sir. Thank you so much for your valuable informations. Now I would like to hear from Dr. Ray, sir. Sir, so far you would have been in the discussion, like we are discussing about the challenges faced in accepting the unclaimed bodies, sir. So could you please let us know like how these challenges can be solved? Do you have some solutions for this, sir? You can just enlighten us with your experience.
Thank you very much. Can you hear me?
Yes, sir. Yeah, you're audible, sir. You can go ahead.
Now, we are at AIMS New Delhi. We are a bit 35 donations, and most of that we use for our undergraduate and postgraduate teaching, and the remaining we when necessary give to some other medical colleges as and when it is required, and we are not taking unclaimed bodies as such. But I will like to point out a few things about the voluntary body donation program, which has been mentioned previously in this session. Now, the first thing I will like to mention is that the voluntary body donation program is not a difficult entity.
Yes,
It can be done very easily through the medical college or institute, or through the voluntary NGOs.
Yes,
Now, first I will
excuse me.
So in this regard, the NGOs are playing a very important role, and
Sir, actually, we are having a session in towards the end, sir, like how to go about with the body donation program. Like
yes.
we'll finish one by one, sir. Like we'll finish off this things, whatever we have to do in said case of unclaimed bodies. Then we'll move on to the body donation program and how it can be done smoothly, sir.
So regarding
Thank you.
the challenges, I just want to highlight few things.
Yes, sir.
I have also worked in other institutes, other medical colleges, and I would like to draw the attention that for unclaimed bodies, by the time the body reaches the anatomy department, the body has started some amount of decomposition.
Yes, sir.
Because 2 weeks have already gone by trying
Yes,
to
sir.
search for the relatives. So some
Yes,
amount
sir.
of
That's
decomposition
what I
is already.
explained.
So we need to adjust our embalming protocol accordingly so that we are able to stop the decomposition petrification process completely. The other thing which Dr. Rajshekhar has said is that about the HIV and other infectious diseases which may be prevalent in in some of these cases. And it is necessary that all the MBBS students should be advised to get the hepatitis B vaccination as a mandatory protocol before they enter the anatomy department. So this advice can be given to all.
Thank you so much.
Thank you.
Thank you, sir. Thank you so much for your valuable input, sir. It's well taken. So in the end, like everyone is very concerned about the time. That is really has to be addressed, and we can frame protocol. We'll try to frame a protocol for reducing the time limit and getting the body in time. Like we do have certain situations like after accepting a body that is thinking that it is an unclaimed body and doing all the procedures, sometimes the body, I mean, the relatives may come and they will ask for the body, unclaimed body. So I would like to hear from Dr. Kumaran sir, like if there is any, do you have any experience of taking out the, I mean, accepting an unclaimed body later on, it has been claimed by their relatives. In that situation, what has to be done? Could you please share your experience on this, sir?
Yeah, just a minute. So there is a provision in the Anatomy Act that there is a dispute arises. Am I audible? Am I audible?
Yes, sir. It's clear. You can go.
Yes. First, I'll go with the Anatomy Act, then I'll go with the other procedures. I have personally not encountered such a situation. I think
Yeah.
other panelists may add up to my point if required. There is a provision in the Anatomy Act. If there is a dispute in of the body, suppose once we are branding it as unclaimed bodies and there is a dispute arises, and there is a protocol that it has to be referred to the magistrate court. The magistrate court will clear the dispute, and till that time, the body has to be preserved in proper condition. The provision, this provision is there in the Anatomy Act itself. And second thing is, suppose we are using the
Who
body.
is responsible for preserving the cadaver? I mean, unclaimed body, sir. Which department will take up the responsibility?
Basically, the appropriate the authority in charge, as per the Anatomy Act itself, he itself should be, and if he gives under the Anatomy department, since we have started using it, claimed it, we can preserve the body.
Yes.
Till the dispute is settled by the magistrate court. And suppose if at all we have started dissecting, so such situation may arise. So immediately we have to stop stop dissecting or proceeding further with the dead body. And second thing is verify the claimant. So immediately once the claim comes to the hospital to you that it is someone is claiming that body, so we have to immediately go to the file a case, file a complaint in the nearby police station, and we also inform the authorities in our hospital also. And second thing is we have to cooperate with the police, and if police again it will be proceeded with the court of law. And if the body, if they say that if they could find that this person is a legal claimant, then we should be in a position to hand over the body also to the.
Yes, sir.
Add in the protocol of body reception. So during the time of reception, we were discussing about identification, photograph, fingerprint.
Yes, sir.
I wanted to put it in the forum. If a rare situation of claim arises, it may help it out. So there is a protocol. There is a small test called FTA card, which comes around a small strip size. Many would have known it. Since we are receiving the dead body within 4 days or less than 48 hours, why can't we preserve the DNA of the unclaimed bodies also for a long term, so that if at all a claim arises in the future, this could help come to a rescue. And this it is not there in any of the protocols, but just I wanted to ask to the other panelists whether we can preserve a blood for the DNA for future settlement of this type of claim. So this question I just wanted to ask the other panelists also before my.
So this question is open for all the panel members. Panel members kindly can respond to this question, and you can freely tell your
yes. One more thing in my view, that if at all a body is claimed in the later use, that whether it's or not. So is it punishable or not? As in my point of view, when we follow the protocols in the Anatomical Act, it itself says that once we follow all the provisions of the Anatomical Act, so no, it is not punishable offense. So it is a claim. Once it is disputed, it has to be returned to the legal kin if required. So, so the claim of punishment or legality should not happen if all the provisions of the Act is followed.
Yes, obviously that should be happen, sir. Now the question, as sir put in the panel, it's open for discussion. Like any of the panel members would like to few enlights on it.
Can you spell out the question, please? We were not able to hear clearly.
Whether shall we, as a protocol, preserve the DNA of the unclaimed bodies, if at all there is a future dispute of claim?
Yeah, that's a very important point and very interesting point. DNA, I think if no claimant has come for, I was in Balasore during the train accident, embalming the victims of the Balasore train accident. And we embalmed about 100 cases or so during that time. So what happened was, before we took up the embalming, the victims' teeth and where it was not possible, some other body part like buccal mucosa, etc., was taken for the gene identification, for the DNA fingerprinting. So yes, this is a very, if no claimant has come within 14 days, I think it should be taken, the DNA identification sample should be taken so that whenever some claimant comes in, the person can be, at least there will be a closure of the case that this person has been. Another point is that we generally, when we get the donation, we don't use it immediately. As one of the previous speakers has said, we keep the body with us for about 6-7 months, and only then 1 year, and then only we use the body. So if such a claimant comes and it is established by DNA fingerprinting that he is a genuine person, we should hand over the body to the claimant.
Yes, sir. Any other panel members want to add to this? So,
Here, there is an interesting question like who will
preservation of DNA.
Yeah, who will actually request for the preservation of DNA? Will it be the investigation officer or will it be the medical superintendent of the, hospital?
May I answer that question, madam? So in Balasore, we saw that we had a forensic team also from Delhi, and they were collecting the specimens before giving us the bodies for embalming. So I think the forensic people are the best persons to collect the sample for DNA fingerprinting.
Yes, sir.
Sir, Rajsekhar sir, the thing is, since the body, the unclaimed body is fresh, we have FDA card. So if a few drops of blood in the FDA card will preserve the DNA for over years. So it is, once we receive the body, we can take some drops of blood, put it in the FDA card, dry it, preserve it, and keep it in the confidential file. So whenever there is a claim happens, we can retrieve this and we can go for a DNA matching. So not big techniques are involved in taking. The FDA card, a drop of blood is sufficient for the DNA preservation.
Yes, sir, I get that. Since it is an unclaimed body, so the body cannot give an explicit consent. So therefore, somebody has to take a call and give that order to collect the DNA. So the onus of giving the order rests with which person? That's my question.
That is my question to the panelists. Should we include in the protocol to take it and then preserve as a protocol of the identification process, to take it as a protocol and preserve in our confidential file? That is one of the part of my question itself.
Sir wants to introduce, it seems, sir. Is it possible you are asking for a provision?
Done as the institutional policy also.
Yes, sir.
Every institute have their own policy. They can add in their policy and they can approved by their body and they can keep it there.
Yes, sir. Definitely it's a good idea and it has to be implemented. Sure.
And one thing I'm telling that whatever you do, whatever the challenges you are facing,
yes, sir,
you have to hand over the body with the proper information to the magistrate. And for that, you have to keep all the documents with you. It is not just like just hand over the body. You have to keep all the documents.
Yes, sir.
Starting how you body and how you hand over the body.
Yes, sir.
Court or any court of law.
The voice is not audible, sir. Voice is not audible, sir.
Now it is audible?
Yes, sir. We can hear now we can hear you, sir.
My thing is that all the things should be properly documented.
Documented, yes, sir.
From starting from collection of the unclaimed body at your institute, and if there is a claim by someone's, then to hand over the body, all the things should be documented so that in future, if anything happens in front of the court of law, you can substantiate your evidence.
Okay, sir.
It's not like that just someone come and tell you and you just hand over the body.
Okay, sir.
Proper documentation is very, very important in this case.
Yes, sir. Documentation will save us from all the issues, right? Right. Well taken, sir. Well taken. Sir, with this, we are concluding our discussions on the unclaimed body. So I'll keep the forum open for other panel members to add anything regarding the accepting an unclaimed body for a medical education. If any of the panel members wants to add some insights into it, you're pleased to do that.
So there was a question in the chat box if there is any claim for the unclaimed body at a later stage. So if there are any such claims, we are mandated to hand over the body irrespective of the situation of the cadaver, whether it is in cold storage, whether it is post-embalming. We are actually required to hand it over to the relatives.
That's what we have discussed, no, sir. I think Kumaran sir told like it has to be intimated to the magistrate, and magistrate had to take a call with the documents what we are going to provide. Isn't it like that, sir?
Yeah, that's correct.
Yes, sir. Yes.
You have to, if someone is asking that dead body belongs to my family, or first you have to establish a relationship between the claimant and that body.
Body, yes, sir.
Without that, you cannot proceed.
Yes, sir.
You have to claim. First, you have to establish that what is the relationship of the claimant with the dead body.
Okay,
It's more important.
Yes, sir. So legally, all the formalities has to be done, and then only they can claim for the body. Yes. So with this, we can close our session on the discussion on unclaimed body, and we'll move on to unregistered voluntary whole body donation. So in this regard, there is a lot of clash in decision making in accepting an unregistered donated bodies. And there are many situations, if it is hospital death, what has to be done? If it is a home death, then what has to be done? And nowadays, we can see like many people from the old age home also, they are willing to donate. But there are some clashes, there are some gap in the society for these people to particularly reach in a particular place, the respective place, and they are willing to donate. But there are some things which has to be cleared before doing all these things. So there are few queries always in our mind, like who can give the consent in such situation, and if there is a difference of opinion among the relatives, what we have to do, and particularly identification of the body, how we can identify the body, dead body, whether it has belonged to that particular person originally or not. So I think like we can give a few insights regarding this. So I would like to hear from Dr. Ray sir, what are the procedures followed during body donation? Say either registered or unregistered, what are the procedures? Like in your institute, you said like you are having ample number of donated bodies to you because of your body donation program and all. It's very interesting. So could you please enlighten us the procedure followed during your body donation, either registered or unregistered?
Okay. So first I will tell you about the registered donated bodies. For the unregistered donated bodies, the people from the home or the people associated, friend or some other person, known person who is associated with the deceased person, they contact us for the donation, whether it is from an old age home or somewhere. And we follow a very simple procedure. The primary and the most important thing is to have the death certificate from a registered MBBS doctor, and where the cause of death will be given in the way that whether it is a natural death or whether it is an MLC death. So in case we have the death certificate from a registered medical practitioner saying that it is a natural death, we then come to the next step, which is to identify the person itself by the Aadhaar card or the voter identity card. And then after identifying the person and getting the cause as a natural death of the person, we then approach the police authorities for giving us an NOC. So in our experience over the last more than 30 years, we have never faced any problem with the police authorities in giving the NOC, provided that the doctor has given the proper death certificate. Sometimes we have issues with the broad dead clause, that sometimes the doctor is not giving the certification and saying that it is a broad dead clause.
Yeah.
So in case of broad dead, it may be argued, but what we follow is that in case of a broad death, if the person's medical history suggests that he was a cardiac patient, or he was having some cancer patient, or say prostate cancer in males, or so there is a medical history, and the doctor is saying, no, I will not give a natural death. I will give a death cert. I will only give the broad death certificate. Then we also approach the police for giving us an NOC, and we accept the donation. We don't say that we will not accept the donation. So this is for the unregistered donor bodies. We establish the identification, we get the medical death certificate, and sometimes when we have queries, we call up the medical doctor to find out exactly what has happened, to clarify, because it is very easy to get his phone number. And the third thing is to get a NOC from the police. Now, if the patient is very aged and there is a definitive medical history that the patient has had a pacemaker implanted, or the patient was suffering from severe hypertension, or there was some heart disease, etc., then even in those cases, we don't wait for the NOC from the police. We start the embalming procedure at the earliest. So varying from case to case, we modify our procedure to adjust to the situation so the body does not get spoiled.
Okay.
Madam, regarding the registered donors, the point, can I tell about that also?
Yes, yes, sir, you can tell.
Now, the point which I heard in this session, I will like to just bring in the most important point. Now, I was the in charge of the body donation program here in the department for the last 5 years.
Yes, sir.
So I used to keep my mobile phone on throughout this period, 24 hours. So whenever I got a call from the relative that somebody has passed away and he was our registered donor, we have a understanding with the ambulance people, private ambulance operators in Delhi and around Delhi.
Okay.
So we also take bodies from NCR, and I immediately contact the ambulance person, and I tell him to immediately go to the home or to the hospital and fetch the body.
Okay.
We don't wait for the relatives to bring the body to AIMS.
So one
We
thing,
see-
yes, sir,
Yes.
who will be taking care of the charges and also travel
Yes,
charges?
yes. So we get temporary advance, which we call impressed money. All government institutes and even private institutes, department gets the temporary advance. So I am telling you the exact amount, I take about 35,000 rupees in advance from the AIMS for about 2 to 3 month period. And each visit where the ambulance reaches the patient's home, waits for some time, and brings back the donation case along with the relatives. takes about 2,500, or sometimes it is near 2 it is 1,000 or 1,500. So I immediately pay from this advance the ambulance person, and what happens is whenever we require the ambulance, immediately the ambulance is dispatched to collect the person. Now, if it is in the night time, we keep the body in the forensic medicine mortuary, because we don't know what is the cause of death. Though we need that, we have the death certificate, but we have not yet spoken to the relatives. We don't know what is the actual situation. So we keep the body in the forensic medicine department in the night, after taking due permission. Then in the morning, we call the relatives, check the certificates, talk with them, and then if we are satisfied, we bring the body to the anatomy department.
Sir, if there is a difference of opinion among the relatives, how can be handled, sir?
Till now, madam, this is a very important point. I will like to mention our experience on this.
Yes,
Whenever there is a difference of opinion, we do not accept the donation.
Okay, that's
We,
fine.
we have the instruction manual which we give to our registered donors. It's a pamphlet where we say that the donation is entirely voluntary. If even one sibling or the wife or the spouse tells that no, I don't want to donate, then we immediately tell them, please don't worry, it is not mandatory, and you can proceed with the funeral as it is.
Okay, sir. So that is fine. So that is what is followed in AIMS Delhi, sir. So
Yes.
nice to hear, sir. Thank you so much for your valuable information, sir. So now I would like to receive from Dr. Rajshekhar, sir, on how do you decide, sir, whether to accept or reject a donated body? And also, how can we identify any unregistered bodies? If registered body means we may be having identification marks, we can cross-check and verify. But in case of unregistered bodies, how will we identify the body and how to decide whether to accept or reject the donation? Could you please enlighten us, sir?
So, for all practical purposes, the registered and unregistered bodies are almost same. So when they're coming to the anatomy department, we are supposed to check the so-called death report and ask for any identification document of the deceased, and also the person who is actually accompanying the body, that is the next of kin of the deceased. So what we usually do in JIPMER is we collect the Aadhaar card of the deceased, and we also ask for Aadhaar card of the next of the kin of the deceased, where the relationship is established within the Aadhaar card, that the person is actually related to the deceased. So after making sure of these two things, then we actually look for the place of death. If the place of death is an institutional death like hospital, then we have a clear-cut case of cause of death. So we don't have any worry regarding the foul play. So we accept it. But if the place of death is at a house or any other place other than hospital, then we insist on the death report, that is the certificate of medical cause of death, like as it was discussed earlier. And we also insist on getting the police clearance certificate.
Okay, sir. So to accept or reject the body, only in the documentation and the other things are okay, we can accept. Otherwise,
yeah, first these are the things. Then comes the nature of the body, cause of death, all these things. In case of any infectious diseases like tuberculosis, usually we don't accept. And in case of any COVID or similar conditions like HIV, hepatitis B, we don't accept. And if there is any signs of decomposition, severe decomposition, we do accept. But then we will actually utilize the body for some other purposes like making specimens or getting bones out of it.
So
Something
it
like
is our responsibility as an anatomist to completely check the body for the foul play also, and then for the medical records, and then we can decide upon whether to accept or not. Is that the thing, sir?
so that foul play part is actually checked by police and forensic if the death has happened outside the hospital. If the death has happened within the hospital, we need not worry about it because hospital itself will give the cause of death.
Okay, sir.
So at that point, we are only worried about the entire documentation part and the condition of the body. That's all.
Condition of the body, medical condition of the body. Okay. Thank you so
Fitness
much.
for embalming.
Yes, sir. Thank you so much, sir. Next, I would like to ask Dr. Ravita ma'am, what is the protocol being followed in your institution, ma'am? Having said like what has been done in AIMS by Dr. Ray sir and Rajshekar sir explained clearly what is done in our institute. Please, can you add upon what will be the protocol in your institute also, ma'am, so that we can get a clear knowledge of all over the India nations, how it has been happening over there.
Ma'am, I was clearly listening to what Dr. Ray has said, and it is almost the same protocol that we are following at our institute also. Maybe because it is AIMS Delhi and we have been instructed to follow up what
the same.
yeah. And as sir said, we also are not taking unclaimed bodies. Most of the bodies we are receiving are the registered and unregistered bodies. So the similar protocol is being followed if it is a registered body, or even if we get a call for unregistered body, being the body donation program coordinator here since the inception. So similarly, I tried to arrange an Harsay van for my institute, which has not been supported by the institute. So we have also followed the same thing as sir has said. We have contacted various ambulances, and if the body,
will you be paying for the ambulance also?
Yes, in the similar way as sir has said, from the impressed money of the department, we ask them to bring the bill. And at times, even if the ambulance is not available, some of the donors, they agree to bring the body by their own arrangements. And we ask them that we will pay whatever bill you give me. But in our case, the bill is usually 3,000 to 4,000 rupees, for which we have taken a proper permission from the institutional authorities for paying the bill from the impressed money, and which is then handled by the departmental impressed money. This is how we are handling this. And regarding the documentation, it is similar to what Dr. Ray has said. We ask them for a death certificate. If it is in hospital death, then they usually have a death certificate with them. And in case they are not able to arrange for the death certificate, we usually deny to take the body. For that, we have not followed. I have asked police to go for NOC cases. In that case, what I have understood is there's a delay, and the relatives do not like to get it done. Maybe because we get bodies mostly from the village people who are not willing to go for this NOC and all. They feel it is an insult if they are giving a body and they want to go through police and all. So in that case, we refused to be on the safer side right now, because the reason for refusal is also that we are in the phase 1 of our inception, and we do not have a very big storage for the bodies. We are getting it built up, so we just like to restrict to what all we can handle. And second thing that I would put forward is, in the previous institute where I was working before coming to AIMS, we had a burial ground which was active and which was being used. If some of the bodies that are being given to us are not in the condition as Dr. Rajshekar has said, we would use it for the purposes for bone retrieval and other purposes. So in this, like most of the protocols that we are following are similar to what Dr. Ray has said. And I agree to what both my learned anatomists have shared regarding the registered and unregistered bodies being taken at
I would like to hear from you, ma'am. Like NGOs also helping you, ma'am. Like as sir told in AIMS, sir is getting from NGOs. Is it true in your institute also, ma'am?
Yes, ma'am, it is true for my institute also. Initially, to begin with, it was the NGOs who helped us in the donation, but there are certain problems that we have also faced with NGOs. I have 3 to 4 NGOs who are very active in donating bodies at my institute. So with the period of time, one end of the NGOs have backed up. There are reasons. If you would like, we would discuss it in other question where you ask us regarding NGOs. And then few of the NGOs are very active. So there are, we have worked with 4 to 5 NGOs. Most of them are really active. And since over a period of time, we have built a vast bank for registered body donations. And recently have started receiving bodies through registered donations also. So we have ample of bodies and enough to support the teaching purposes of our institute.
That is not
Yeah. So we have been holding the fresh cadaver workshops also, and the surgical workshops, whatever required is being done. So the donation that is happening here is enough to run my teaching and research purposes.
That's very happy to hear, ma'am. Your students are blessed to have such nice institute and ample number of cadavers. Like
Look, add something. So when a donor comes to us for body donation,
Yes, sir.
we take their photographs,
Yes,
we
sir.
take their photocopies of their ID,
Yes,
and
sir.
we issue them a donor card.
God, yes, sir. That is the
Particular
procedure.
number on that.
Yes, sir.
So what happens is when this registered donor comes to us after the event, then we are, and they show us, the relative show us the donor card.
Yes,
We
sir.
are generally satisfied that the identity of the person has been somewhat established. So our work becomes correspondingly
Simple.
less. It is
Yes.
a registered.
Registered.
And another
Unregistered.
point, madam, I would like to tell you that when we have sufficient cadavers with us, we often take the privilege of refusing sometimes and
Yes, sir.
directing the donation to some other medical college in Delhi NCR region.
Okay.
But when there is the request of donation from a registered body donor, we never refuse, even if we have sufficient number of cadavers with us. So
Yes,
a
sir.
registered body donor is never refused donation in
Okay.
AIMS.
Yeah, that is nice to hear, sir. It is
Yeah,
like an honor we are giving to them. They have given their
Yeah.
consent and you are accepting it without denying. That's good, sir. That's really good.
Similar, ma'am, we are also following the same thing. If the donor is registered, it is our duty to take the body, and wherever they ask us to take it from, in whatever manner they want it to be done, we respect that donation. And if it is an unregistered body, we take the privilege of refusing if it is not with the protocols or we have some
Yes.
doubt regarding the death.
Of course, we can do that, ma'am, because documentation is always needed for us to make us free from all the other issues.
Yes.
Like, thank you so much. Thank you, sir. Thank you, ma'am, for your insights. Like, now there are a few things to be discussed on the protocol for unregistered donated bodies. What is the procedure to get a no objection certificate from the police station? And I think this I can ask to SSP ma'am, since ma'am is no on her way. Like, can I request Dr. Kumaran sir to enlighten us regarding this? What is the procedure to get a no objection certificate from the police station regarding body donation in case of institutional death? What has to be done in case of home death? What has to be done, sir?
Am I audible, madam?
Yes, sir. It's feeble, sir.
Am I audible?
Voice is very low, sir. Very low. Voice is very low.
So SSP madam is not available now. So I don't know how to proceed with this question. Shall we skip for Tam so that we can put it in
Yes,
the...
sir. Sir, we can hold this for madam to come and
Yeah,
answer.
we can take the answers from the madam and put it in the email for all the
Okay, sir.
participants.
Because we all are very fond of knowing like what is the procedure, because in the previous discussion, what was the main thing which was kept in the panel was like everyone was in a need of a clearance certificate before accepting the body. So obviously we will be very much eager to know the answer for this. So kindly do the needful, sir.
Yeah, I will just put this question to madam, get the answer, and we will share it to all the participants.
With this, I close the session on unregistered body donors. We'll have a few queries on the registered body donors. Yes, registered voluntary body donation. So what are all the challenges faced in the acceptance and timely embalming of the registered body donors? Actually, sir and madam had shared enough, but in continuation of that, anything to be added, you can add, ma'am. What is the procedure for the challenges faced during registration of the body donation, sir? Like whether everyone will be giving willingness, and as sir told, if one is going to deny, yeah, you are not going to take, that is good. And transportation also, you have done everything. Regarding this verification of certificates, could you please enlighten us more? What all the certificates you will be asking for in your institute, sir? Dr. Ray, sir, can you just tell me about the certificates? And if it comes outside the official hours, what will be the procedure, sir?
Yes. So I will first tell you that I will take the opportunity to tell you how we register the donors.
Yes, sir.
Now, if the donor is very old and not able to come to the department, we do it online.
Yes,
we send through email, we send the document, and the person fills up the document, gets the signature from the children or from the spouse, and then sends it back through email after scanning it. So we don't make it mandatory for the registered donor to come to the department. It can be also done through the post.
Okay.
It can be also done through the post. Now, so we have tried to make the registration for body donation as simple as possible, without any inconvenience to any person.
That is nice to hear.
So challenges faced during registration for body donation, we sometimes get people, very angry people in our department, because they sometimes say we are not able to find the way to the anatomy department, and sometimes they are very much annoyed by themselves and they start shouting sometimes. But we have our protocol for we offer them water, cold drinks, or some food, and we talk to them very politely. So all these things matter when we get very aged persons who have come for body donation. And regarding for registered body donors, we when the person comes for registration, we have two questions for them. How many are your blood relatives and near relatives? And are they all willing to agree for the donation? And we have a will form.
Yes, sir.
So the person fills up the will form that I, this, living here, he's agreed to the body donation, and my relatives whose signatures are below are agreeing to the body donation. So the person signs and he puts his name, etc., his address, and then all the relatives or most of the relatives sign there. Those relatives who are out of station or who are abroad, they cannot sign. But we get the idea that yes, those people who have not signed is also not unwilling to donate, to agree to the donation. So we, at the very point of registration, we make sure that all the relatives are agreeing to the donation. If even if one person is not agreeing, we don't register him in our system.
Yes, sir. That is nice. It is very happy to hear like you are having an online portal for body registrations, because many of the people here, they are finding very difficult to register their body. They have to travel a long distance. They have to come to the particular institute and they have to fill up the forms, and it was very cumbersome. Like if they have an online option, definitely I think we can increase the number of donors in future. In this regard, a few questions to Madam also. I would like to hear from Navita ma'am, like which strategy is followed in your college to promote registration of body donation?
Ma'am,
yes.
To promote body donations, in the beginning, we had tried to conduct some Nukkad Natak type of programs in the foyer of our OPDs, so that we have a lot of patient load and people become aware of that. We motivated our first year students to conduct those motivating programs, and we, along with the CFM, with the help of the CFM department, try to reach out to the associated villages to motivate the people. And then one thing which we have been helped by our NGOs also, if there is a donation, we try to just thank the people through a small clipping in the local newspaper, so that people are motivated. And mostly like what I see is a group of 20-25 people coming with the body donation, and we try to talk to them also, listen to their problems. And what a practice that we are seeing here in Punjab is people would like us to come to their places when they are the last riots of the person, and we try to send a person who is good at the local language to reach these people and talk about the donation and Thanksgiving and the benefits of donating the body to the public. And this is how we think we have been able to promote that program in our area, and because of which and second thing, what as Dr. Ray has just now put on, that the form for body donation for AIIMS Bathinda is at our institutional website. It is a separate page, and by the word of mouth, it is spread to most of the people that anybody who wants to donate the body or get it registered, they go through the they call us. We tell them there's a the form and everything, details are there. All the FAQs have been put on the website, so you can go through that. If there are issues, we solve the issues. And as sir has said, we also handle the online and through postal declarations, whatever they want, we make it easy for them to register the bodies in whatever way we can. And I am being the coordinator, I'm 24 hours available on my call for anybody who wants to get registered and information if they want. I still have a question with Ray, sir. If ma'am you allow, I would like, it is concerning to this only, which I've not been able to solve it.
You can ask me. You go ahead.
Ray, sir, can I ask a question?
Yes, definitely.
So one thing what I have once upon came across a case was we had a registered body and the person is willing to donate the body. Initially, we had the signatures of the two witnesses and the next of the kin on the form also. The entire protocol was followed. But at the time of death, most of the people, the deceased was willing, that is why the body was registered. The kin next to the kin had also signed, but at the time of donation, there was a dispute. Like one or two of the children wanted to donate, others did not want. Means the condition was not similar to what it was at the time of registration. So in this case, we were in a dilemma whether to respect the will of the deceased to donate the body, which is already registered, or to go by what the people who are there now talking about not to donate. So in that case, I would like to be enlightened on what decision has to be taken. Means I go by the point that whose body was there, the person wants to donate, even if the kin is not interested, we should take it. But then we were not able to reach any conclusion. I would like all the learned people here to give inputs on this kind of an case.
So, madam, which we follow here is that the claim for the permission for donation rests with the next of kin once the person is no more. It is not that at that point of time when he was alive, he has donated his body. But once he has passed away, the claim of the donation body rests with the next of kin. That is more primary for us than the donation form which the person has filled up earlier. I will tell you even of cases where...
One second, sir. Sorry for the interruption. One small network issue, sir. I'll just log out and come back in 2 minutes. You can just continue, sir. You can just continue. Thank you.
So, is this point clear, madam? That
yes, this point I have understood. But I mean, maybe because it is a law that the next of the kin has a right to the body. But what about the will of the person who wanted to donate his body? When that is a dilemma which I have still not been able to come out of it. By law, yes, the next of the kin is right.
Yeah, but we have deliberated it and also from all aspects, and we have found that in such a case, even if you, the first point is that we should not accept it if some of the kin, not all, some of them have a problem with the donation. Second point is the person who is not with the, who is not agreeing for the donation, that person may go to court.
Yes.
That person may go to court and create problems for the faculty of the department, and we have to do some extra work regarding that. There were few court cases in this regard, but not with in this relation. So it is better to avoid all controversy when we are accepting donation. And respect the, I will tell you one case where the donation, we had brought the donation body to the department. It was in the afternoon, about 5 or 6 months back. And there were 3 or 4 children who had come. And suddenly one of the children said, no. When I explained to them that, are you all willing for the donation? Because even when a registered donor comes to us, and the siblings or the spouse are there, again we confirm that whether they are willing for the donation. So then when I told them that, are you all willing for the donation? Then one of the one of the person, son, asked me, can we refuse if we want to? I said, yes, you can refuse because you are the son, you have a greater responsibility. And so he said, no, I don't want to donate my father's body. And I told him then, okay, you take him back. We will not accept the donation unless all the relatives, all the blood relatives, all the near relatives have agreed to the donation. So it is better to avoid any type of controversy in relation. And at the time of when the body comes for donation, we fill up a separate form. Yeah, madam, you may be aware of that. And there, all the relatives who are there, they sign, who have come with the body. So there is no chance of any controversy that sometimes later somebody will say, no, I did not agree. Even if somebody is staying abroad, some brother or children are staying abroad, we get an email from them. We accept the donation, but we tell them that you give me the email ID. I want to contact them, and they send us the email, the response email, that we have no problem with the donation process.
Yes, sir. I think we
So
can move on to the next question, ma'am. Because it's already lunchtime and all we feel hungry. Yes, in this regard, now I would like to call upon Dr. Hemal, ma'am, who is a renowned NGOs, and he's very famous. I mean, he is doing lot of works in body donations, organ donations, and madam had a lot of ideas also to promote body donation. Welcome, ma'am. Sorry for making you wait for a long time. Like, kindly let us know about how to facilitate this body donation, ma'am. What will be the role of NGOs in assisting transfer of the registered bodies? Like in some institute, as sir told in AIMS and Bathinda, Punjab, the institute itself is taking care of. But in our institute, like we won't be providing that ambulance support, vehicle support, and also people will feel difficult, and we don't have that online option also to register. So all these things are in favor of more getting more body donors. Like you can just enlighten us. Can they facilitate all the NGOs? Can they facilitate in getting the necessary certificates, and will they assist in the transportation of the deceased bodies, ma'am?
I just first want to thank JIPMER for recognizing the work of Mohan Foundation and especially recognizing the work of NGOs. There are many NGOs who are like doing a lot of work on on body donation, but thank you for inviting Mohan Foundation. The role of NGOs basically is in public advocacy towards body donation, and most of them are also supporting by coordinating the body donation. They also support the family by getting a doctor to come and do the certification. All of that also the NGOs do. But very few NGOs are able to do the transfer of bodies to a hospital. Some of them may have funds to do it. Mohan Foundation is not doing that work. I do not know of any other NGO, maybe Dadichi Dedan in Delhi area, northern area, may be doing and supporting the families to fulfill the last wish of the deceased. And do we have registration facility? Oh, we have a lot of NGOs who are doing this work, and in Mohan Foundation website
Is there
also
any
there is
forum for registering themselves to be a part of this program, ma'am?
No, there is no. In your mission and vision statement of the NGO in the bylaws, you can say that we will be working on this, and they continue to work. They don't need to register anywhere. But for organ donation, we need to register in the national authority. This is a state subject, Anatomy Act, a state subject. So there's no national authority. So that is why NGOs do not need to register anywhere to conduct programs to motivate public to become, register as body donors or any of that sort. They don't need to be part of it. But another part of the NGO's work is, getting people to say positive things on body donation, Especially NGOs have a lot of groups of social workers, of different interns coming to the NGO. So they are able to do what ma'am had said, Navita ma'am had said, that street theater, some things like that. If your departments can approve social work students to come and be with you for a month, develop some material and tools to provide, ways of doing public awareness, it will be very good for the department as well as for the students, because they are social work students. They will be working in social work field. And wherever they get a job, they will continue to have that. So then internship program within your college or your department would be good. 15 days exposure visits, things like that would be very good for the promoting the cause of body donation everywhere. other NGOs can do is, create more tools, maybe in social media, maybe YouTube videos, things like that you can, do for organ donation. I mean, body donation.
And what is your advice and opinion regarding the body donors, ma'am?
I would suggest that, you have some senior surgeons come and do the felicitation of body donors. Okay.
Okay.
Your
Okay.
HOD is an eminent person.
Yes, ma'am.
But direct link, the family should know that where did the body support?
Yes,
What
ma'am.
happened to the body? How did the body support the knowledge? So if some surgeon comes or some clinician comes, and does the felicitation of the body donors, it becomes two-way also.
Yes,
It
ma'am.
also reminds the surgeon that from where he started.
Yes, ma'am. Yes.
Sometimes we forget what was the basis of our learning.
Yes,
When
as
we
you
go
rightly pointed out, like organ donors, they are thinking that they are saving life. And
life,
the
yeah.
body donors, they should have that feeling like they are also
Yes.
saving life. If
Yeah,
they have that
absolutely.
feel, they will definitely come and they will
Yes,
donate their body.
Yeah,
Rightly
sure,
pointed out.
sure.
In what way NGO steps in this place, ma'am? Space?
See, we can create lot of uh, learning tools, IEC materials, which
Okay.
will be good in vernacular language, will be posters, would be, short videos, things like that. NGOs can create because they are very good in communication with the community.
Okay.
And that is one thing that NGOs can do very well.
Okay.
Apart from actually facilitating or body donation, public awareness, public advocacy is a major part of all NGO activities.
How can we involve public, ma'am? Like, what are all the benefits and challenges of doing so? Involving the public in creating awareness of body donation.
There's only benefit in creating awareness. There is no challenge in creating awareness for body donation at all. We should never have that point that there may be a challenge.
Okay.
It's always good to have, there's always benefit of doing it. The way to do it is different things. You can have radio programs. You can have community radios are there nowadays. In community radios, if you give a short question answer or an interview of 15 minutes, it's very good for the community to come to know, okay, this is possible. Most of them do not know it is possible. The frequency of getting a body donation has lessened because people do not know it is possible in the community.
What kind of incentives the family members are expecting, ma'am? Because you are more with the public, you will be aware of like what they are expecting. If they are doing something if something can be given as an incentive, it will be creating more awareness. No?
Okay, for Mohan Foundation, we do not promote incentives for any donation. What we would like is actually honoring the family, what you are doing, giving a certificate, honoring the family. And Namita Agarwal ma'am said that somebody from the hospital, medical college itself goes and does something at the prayer meeting. In organ donation, now Tamil Nadu, Karnataka, MP, Maharashtra, one of the civil officers, the local administrative officer, highest person goes to the family of the organ donor at the time of the prayer meeting. This is something which has really uplifted the organ donation program. So something similar maybe the state government should do, or the hospital should do. Like the senior officer from the hospital should go for the prayer meeting. Most of them do not know whether they are going to get any little bit to do the last rites. The public does not know. That is one question. Do we get something to do the last rites? That is a question. You should be able to answer that question. Somewhere it should be available, maybe on your website, on the website of all the medical colleges. I request you to have a body donation button that I can press and I will get the person in charge for that. Yeah.
Most of the colleges do have, but still there are some colleges which has not been posted.
Yeah,
So we have
need to find it, because we run a toll-free helpline, which is national helpline. And we get calls from everywhere that we wish to do. And when we try to search the medical college, we are not able to find the anatomy department, a person in charge. Whom to call, so we have to call the local number, and then it's difficult to find the person in charge at that time. So some sort of button, body donation button in your anatomy part of your website, there should be. If anybody wants body donation, the form should be there, person concerned phone number should be there, your rules and regulations should be there, easily available, at a button.
We'll try to.
Registration, yeah, registration is very, very
So
important.
we'll take this platform to inform everyone like
Yes.
these all the things to be done. So
Yes.
definitely it will be sorted out in future. I hope it will
Yes.
be sorted out now. Is
Especially
there
for
a
Tamil
role-
Nadu, Kamal Hassan is a body donor, registered body donor.
donor? Yes, ma'am.
Yes, so
Registered body.
yes, so this is something that you should promote, especially in Tamil Nadu. A great
Yes, ma'am.
actor of
Yes.
great eminence and learned person has decided this. Many
Yes.
people would come forward. Things like that would
Okay.
help. Technology is very
Sure.
important. Having a standard registration form, which is like a national registration form, will support a lot of NGOs in promoting the cause.
Promoting cause.
Yeah. Yes. Yes.
And
Yes, ma'am. Yes, sir.
Yeah. Yes. You're free to answer.
we have a dedicated wall of honor in our
Yes.
facility.
Yes, wall of honor. Yes, we were discussing also.
Where we put up the photographs of the donated person, the donor, and we get the photographs from the relatives, and we enlarge the photograph, print it, and then laminate it in the frame, and then we have about I think about 20-25 such photographs. And including in that photograph is also people like Sitaram Yechuri ji, who donated his body, and Sri Vijay Shankar ji, who was the former director of CBI. So this is one way we are trying to, it is not possible to do it for every donor, but we are trying our level best to put up many of the photographs.
And I want to ask one question to Dr. Ray, sir.
Yes, sir.
Audible, sir? Ray, sir?
I am not able to hear you, sir.
Say it is audible
Sir,
to you,
voice
sir?
is very low, sir. Yes.
Now it is audible?
Yes.
Yes, it is audible.
No, sir, you told that you have a portal in your site where you have all the details about the body donations. So there is any platform where you are keeping the photographs of all the donors in that past donors for that reference, if anyone going, so that they will also interested to give the body donations in future. Any
Yes,
past photographs.
very
for
good
the donors.
suggestion. That is a very good suggestion, sir. I will discuss it with my colleagues and upload it on the website. That would be a tribute to the people who have donated their bodies.
Yes, sir.
That is a very good suggestion. Thank you very much.
Thank you, sir.
I think we have discussed enough about our aim today. Like we have to sum up. So we have started our discussions on the unclaimed body. So we do have lot of insights into it. We have at the end we have understood like documentation is very, very important. And another main constraint is time delay in claiming this unclaimed body is really has to be addressed. In case of unregistered donors, the willingness is again a question mark. If any one of the relatives is not willing, again it's a problem for us. And in case of registered donors, the main thing is there should be a nationwide normal common form, and it should be made online portal so that everyone who wish to donate their body automatically can do that in their own convenient place at that own convenient time. And finally, body donation programs are very, very important. It's high time to promote body donation program to a larger extent so that we can get lot of bodies for the medical education, which is going to really help our medical students a lot. So with this, I thank all the panel members for the active participation. Indeed, in-depth conversation with a thoughtful exchange of ideas. It's an eye-opener in many aspects. I deeply appreciate the time taken out from your busy schedule. I thank all the panel members and thank you all, sir. With
Thank
this,
you,
we
ma'am.
close the session. Thank you so much.
Thank you so much.
I'll hand over to Dr. Ambika for the inaugural session.
Thank you, ma'am. We would like to express our gratitude towards all the panelists and panel moderator for sharing their expertise and insights into the topic today. Kindly accept the certificates for the session, sir, ma'am.
Thank you very much.
Thank you, madam.
Dear delegates, now we'll move on to the inauguration of the CME. We thank the Almighty for guiding us throughout the session. I welcome all the chief guests and patron to be seated on the dais. Now I welcome Dr. Saranya ma'am to deliver the welcome address and facilitate our guests.
Thank you, Dr. Ambika. Good afternoon. We are really sorry for the very late proceeding. We'll try to finish the program as early as possible. Very warm welcome to everyone present here. So this day is actually, it marks a very significant milestone in our journey. As a budding institution, we are striving to overcome challenges and push boundaries. I'm very much delighted today to share that this is the first ever national ECME from the Institute of Jipmer Karaikal with around nearly 250 online participants and more than 60 offline participants. So this is a grand occasion for us, and we are very much thrilled to bring the experts from all over the country, and they share their experiences with us. So first and foremost, on behalf of the organizing committee, I welcome our esteemed director, Dr. Negi sir, for his immense support. Though sir is not present with us today, his immense support and continuous encouragement is always there. That is what has made the event happen today. I really thank sir for his motivation. I now extend a warm welcome to our distinguished chief guest, Dr. Kannagi Madam, Medical Superintendent of Government General Hospital, Karaikal. Madam, your dedicated service to humanity keep us very much inspired. Now, I'd like to extend a very warm welcome to Mr. S. Muthasivam, Executive Engineer of Karaikal Municipality, representing BGL. Sir, your presence adds value to this occasion, and we appreciate your contribution to our community, sir. I would also like to welcome our Dean Sir, Dr. Kusakumar Saha Sir, whose vision and guidance have been instrumental in shaping our institution. Sir, participants, and our respected body donation registrants, and all the prize winners, and our dear students to this program. On behalf of Jipmer Karaikal family, I welcome you all to this academic feast. I welcome all the faculty of Jipmer Karaikal, the staff, all the supporting members of this institution. We are looking forward to a fruitful discussion on the journey of anatomical gift. Thank you.
Thank you, ma'am. Now I kindly invite our respected sir, Dr. Kusakumar Sahar, Dean, Jipmer Karaikal, to address the gathering and participants and share their valuable insights.
So good afternoon, everyone. Respected Chief Guest, Dr. Kannagi, Government General Hospitals, Karaikal. And I also thanks our director, Dr. Negi, for giving this opportunity to conduct this ECME. I like to honor the Mr. Muthush Shivam, Executive Engineer from Karaikal, and all the students, faculty members, staffs, and the organizing committee. It gives me immense pleasure and deep sense of responsibility to inaugurate this nation ECME on journey of anatomical gift, procurement to ultimate utilization. This is the subject that lies at the heart of medical education, clinical practice, and ethical science. Before starting my speech, let us begin by paying the respectful homage to the silent, selfless individuals who have donated their bodies to the cause of medical education, research, and advancement. These anatomical gifts are not just physical remains, they are noble legacies that forms the bedrock of our learning. The human body in death becomes an unparalleled tool for teaching and innovations. All of you know, from the first year anatomy dissection hall to the advanced surgical skill labs, body donation forms a bridge between the theoretical knowledge and clinical excellence. This CME is a vital because it draws attention to this often invisible yet indispensable process that sustains medical educations. There are so many barriers, cultural barriers, lack of awareness, and insufficient institutional systems where we are not in a position to get the donations. To conducting such type of conference for a systemic and ethical strengthening of the body donation awareness program, legislation clarity, coordination between the forensic anatomy and legal departments, and digitization of the registries can be made. We are facing so many challenges on our journey. One is the legal ambiguity in accepting the unclaimed bodies, ethical consent, transport and storage logistics, transparency in allocation and uses of the surgical research purpose, dignified disposal and memory ceremonies. So these are the challenges when we are getting the dead bodies we are facing. So we need all the discipline teams to be coordinated equally, like forensic medicines, hospital administrations, and the medical educators and the students. Hence, today's program is not just as academic, it is also a call for the interdisciplinary synchronization and empathy. So we have to way forward, and as a dean of these institutions, I urge all the stakeholders to establish the SOPs for the transparent utilizations and promote the technology for the voluntary body donation campaignings and develop the cadaver skill labs to optimize the teaching potential of each donations. And also you have to already create some memorial events and donor registries as gestures of their gratitudes. So before concluding, this anatomical gift is not just for a teaching tool, it is a profound act of social contributions. Though this ECME, we are acknowledging not only the donors, but also the systems that respect, process, and utilize their gift responsibility. Let this program ignite in us a renewed sense of gratitude, integrity, and reform in how we handle anatomical donations. With these words, I congratulate the Department of Anatomy and the Forensic Medicines and all the collaborating teams and the participants who organized this timely and meaningful CME. I am confident that today's deliberations will lead to enriched practice, enhanced ethics, and improved system nationwide. Thank you.
Thank you so much, sir. Now, I kindly welcome our guest of honor, Mr. S. Muthasivam, ex-military engineering service, associated member of Institute of Surveyors, Bachelor of General Law, Executive Engineer, Karaikal Municipality, to address the gathering with your valuable thoughts.
With Almighty God, I thank to Chipmer and this all faculties and students of this forum. Actually, I came to know that this body donation is one of the very important for medical college students. Actually, next, we are living now. After that, we are not here. Nothing for us. So, kindly ask people to donate their body to medical college by registration or by relatives. That I came to know from this forum. And I will definitely promote to donate the body donors. Thank you for this kind cooperation and chance.
Thank you, sir. I would like to acknowledge the municipality department here that we recently got one body donated through the Karaikal municipality. We are really grateful to the municipality team. So that is through the cooperation of our GH Karaikal. So it is actually like a very big milestone for us. This is the first body that we received for our institution, for our students. Sir, we request you to kindly accept a token of appreciation. Sir. Dean sir, you give Dean sir. Thank you, sir. Now we request Dr. Kanaki madam to address the gathering.
Very good afternoon to all of you. Respected Dean Sir, Professor of Forensic Medicine and Faculty of Forensic Medicine and Anatomy Departments of Chipmar Karaikal, and all the faculty members and the students and dignitaries over and of the dais. And today it was a very enlightening attending ECME that we have attended. So these remains of our college days when we were students, right down the lane around 1979, when I was a student of Usmania Medical College at Hyderabad. We had the privilege of, like now we have a shortage of bodies, but those days the medical colleges also were very few, and the number of bodies also used to be more. And we had an opportunity in which the anatomy students, we could even select our bodies. We used to avoid bodies having more fat so that the dissection process will be more difficult. But we wanted muscular bodies so that we can know the anatomy, we can learn the anatomy in a better way. And our professors of anatomy also, most of them were even surgeons also, who had almost even enlightened us from the point that once you learn anatomy only, you will become a very good surgeon. So learning anatomy, that too live, is a very important aspect. So it enlightens, and it is a very important learn knowledge, to update your knowledge and to learn about the anatomy, then only you can be a very good surgeon. So in those days, we really, our faculty members, those days we did not have much of computers and PowerPoint presentations. So our professors and assistant professors also used to draw the anatomy. And once after the dissection class, we had the anatomy class. Our professor and associate professor and assistant professors used to start drawing an hour before, so that with color chalk pieces, so that with that remains even still fresh in our minds. So, and some of the surgeons, even sir has rightly said, respecting the dead body. So some of our people also, while dissection, we used to apply Alice forceps over the skin. They really used to get very annoyed. So they used to tell that it is a live body, not a dead body, but it's a live model for you to learn. And the same thing you will also repeat when you become a surgeon. So we were never allowed to use Alice forceps on the skin. So these are some of the memories that I could recollect today. And as you know, the government of India has also pressurized more and become stringent on applying laws for organ donation, as well as our Puducherry government also has implemented law regarding organ donation. So regarding this, after death, usually our body naturally tends to decompose, as sir has rightly pointed, our engineer sir from municipality. So our body is going to be remain waste. So it's going to be get decomposed, or even after cremation also, it's going to be in ashes. So if you're going to donate a body, you're going to educate so many doctors and future surgeons and future medical professions who will be able to learn in a better way, rather than from even from e-drawing or from ChatGPT or from your textbooks. You don't try to learn much unless you do it practically, the dissection yourself, and you tend to learn. That will remain in your mind and help you to learn, and as well as update your surgical skill also later. So this is very important point, and the Department of Forensic Medicine and Anatomy have really taken so much steps to create an awareness also, and also to appreciate the donors, cadaveric donors also for the anatomy department. So all of us has to really take it up and also help to publicize in a better way. And we should know that as a person is alive, உயிருள்ள வரைக்கும் நம்ம வந்து நம்மளுடைய உறுப்புகளை தானம் பண்ணவும், நம்மளோட இறந்த பிறகு நம்மளோட உறுப்புகள், கண் மற்றும் உடல் தானத்தை எல்லாருக்கும் கொடுத்து தானத்தை செஞ்சு நம்ம வந்து நிச்சயமாக வந்து ஒரு மெடிக்கல் ப்ரொஃபஷனை நம்ம மற்ற ஜூனியர்ஸையும் வந்து நல்லா எஜுகேட் பண்ணி அவங்க நல்லா கொஞ்சம் கற்றுக்கவும் முடியும். ஸோ இந்த ஆப்பர்ச்சுனிட்டியில் நான் நிச்சயமாக வந்து டுடே இட் வாஸ் அ வெரி என்லைட்டனிங் ஒர்க் ஷாப் சார். We ourselves had several doubts regarding this, and this was almost cleared. So I think we should take it to the help to public to motivate, and also to about regarding this organ donation as well as cadaveric donor also. So regarding this legal aspect also, we could learn more today. So I thank you all for the wonderful opportunity. Thank you all.
Thank you, ma'am.
Madam, we request you to kindly accept a token of gratitude from us. So in the we conducted continuous events to promote the voluntary whole body donation among different groups of population. So we started with the youngsters. We approached them in surrounding colleges in the Karaikal district. We conducted a poster painting competition and a slogan writing competition on voluntary whole body donation. So we are glad to announce the prize winners for the same today. I request the chief guests and the dignitaries on the dais to please come down to distribute the certificates for the winners.
The first prize for poster making goes to Ms. Yuvashri T. Second prize is shared by two, Ms. Joshi B and Ms. Vivika Glancy. Ms. Joshi is from Bhajanko and Ms. Vivika Glancy is our first year UG MBBS student. Second prize. Second prize winners will be awarded a cash prize of 3,000 rupees. First prize will be rupees 2,000 cash prize. Rupees 5,000 for the first place and rupees 3,000 for the second prize. And the third prize, Miss Danusha E. 2,000 rupees cash prize.
slogan